Great, thank you so much, Mark. And again, thank you for the opportunity to present section GG and the quality measure focused on functional assessment. I'm very pleased to be here to talk about this because I've been involved in this work for the past 10 years. There's been a lot of work, as Stacy and Sharon mentioned yesterday, related to trying to standardize functional assessment. And so a lot of this work started about 10 years ago when CMS funded work as part of the Deficit Reduction Act. And so we had many expert panels back then. We had many clinicians that we talked to with in terms of current practices, what they liked about the current assessment tools that they were using, areas for improvement. And since that time, there's been a lot of work obviously put into creating quality measures related to functional assessment. And so again, in the last 4 or 5 years, we've had quite a few expert panels, cross-setting, where we had clinicians, researchers, quality improvement experts from all the different post-acute care settings as well as acute care settings giving us input on these measures. So the title of this section is Application of Percent of Long-Term Care Hospital Patients with an Admission and Discharge Functional Assessment and a Care Plan that addresses function and associated MDS 3.0 items. So as I mentioned yesterday, and I think as Roberta mentioned as part of her presentation, we are using quality measures that are NQF endorsed, and we are actually using applications, so they're modifications of the original quality measures. So the quality measure that's kind of the starting point for the quality measure we're talking about today was originally developed for long-term care hospitals, so hence the title having long-term care hospitals. So we'll talk a lot about the quality measure and more about its adaptation or the application aspect of the measure. So in terms of objectives, I did want to give you an idea of what we're going to be covering and expectations that you will get out of this presentation. So after completing this session, and by the way, we will go for about an hour, we'll take a break, and then we will spend some additional time after the break and this afternoon a little bit. There will be time for questions. In fact, I think I will break at different segments to see if there's questions as they seem to make sense. So upon completion of this session, we hope that you will be able to understand different aspects of the quality measure, including the numerator, the denominator, definition of a complete stay and incomplete stay, just reinforcing what I talked about yesterday. We'll go through the quality measure calculation algorithm, or as we say, the QM calculation algorithm. We'll talk about risk adjustment very briefly, and we will just then go into talking about the actual items, starting off with an intent of the items, and we will talk about the definition of a helper in relation to section GG. I'll provide a rationale for section GG items. We'll talk through the time frames and the steps focused on assessment. We will first talk about the self-care items, and then a lot of that information also applies to mobility, but I'll repeat a lot of the information just to reinforce it and talk about kind of the nuances related to mobility in terms of assessment. And then we'll have a lot of examples throughout the day or the morning talking through the items. There's also a group functional assessment case study in your packet. So you'll have time to do a little bit of work on your own also as each table, and then we'll report back together. So again, the quality measure that we're particularly focused on at this point in time for this training is application of the percent of long-term care hospital patients with an admission and discharge functional assessment and a care plan that addresses function. So as I said, originally this measure was submitted to the National Quality Forum, or NQF, for endorsement for long-term care hospitals. When the IMPACT Act was passed, we decided, CMS decided to adapt or modify the measure so that it could be used for cross-setting purpose and meet the requirements of the IMPACT Act. So this, again, is specified for all the post-acute care settings, including standardized data collection related to functional status, cognitive function, and changes in function and cognitive function as specified in the IMPACT Act. This quality measure reports the percent of residents in the case of skilled nursing facilities with admission and discharge functional assessment data and a goal that addresses function. So the numerator and denominator, I wanted to go over that quickly with you. So we'll start off with the denominator at the bottom. So the denominator is the number of Medicare Part A stays for residents. So consistent with what we talked about yesterday, the population is the patients getting Part A coverage. The numerator is a subset of the denominator patients or residents, and it's the number of Medicare Part A covered residents with functional assessment data for each self-care and mobility activity and at least one self-care or mobility goal. So I use the word activity here, but you can refer to it as an item. Each of the items on the data set, so for example, we'll be talking about eating shortly. Eating in the International Classification of Functioning is described as an activity. So if you want to think about it as an item or an activity, I'll be using those words interchangeably. So again, denominator is the total number of Medicare Part A resident stays, and then the numerator is looking to see whether there's complete admission and discharge functional assessment data and at least one goal focused on function. We'll get into a lot more details, obviously, shortly, but overall, that's the kind of big picture of the quality measure. So when a patient or resident has an incomplete stay, collection of functional status data can be challenging. So I think I gave an example yesterday where somebody has a medical emergency, let's say a pulmonary embolism, and so they're discharged very quickly out of perhaps your skilled nursing facility. And so the person's functional status at that point in time is really not a priority for you to assess. And so basically, for residents who have an incomplete stay, admission functional status data obviously would have been collected already. At least one treatment goal could have been reported at that point in time, but the discharge functional status data would not be required to be reported for that individual. So I want to give a little bit more specific definition of incomplete stay. So residents who have an incomplete stays are defined as those patients who leave due to a medical emergency, those who leave the skilled nursing facility against medical advice, or those patients who pass away while in the skilled nursing facility. For the patients who do not meet the definition, for the residents who do not meet the definition of an incomplete stay, then a complete stay would be assigned to that person. So if they don't meet the criteria that I just outlined, they'll be classified as having a complete stay. So in terms of the algorithm, the first step is for each skilled nursing facility, so each provider, the records of Medicare Part A covered resident stays meeting the inclusion criteria, so that's the denominator that we just discussed, who were discharged during the 12-month target period are identified through the review of the records and counted. The count is the denominator. So if we said that, let's say, we're in the future and we had data from, let's say, calendar year 2017, then any resident covered under Medicare Part A who have had the end of their SNF Part A stay during that calendar year, so January 1, 2017 through December 31st, 2017, if it's calendar year 2017. So anybody discharged who is Medicare Part A covered would be included in the denominator. So in step 2, for for the calculation algorithm, the records of Medicare Part A stays with complete stays are identified, and the number of those residents with complete admission functional assessment data. And there are, by the way, various codes to indicate that it wasn't safe for an activity to be performed or that a patient refused, so we'll cover that in a few minutes. But basically, there needs to be a code to indicate that a functional assessment was completed for the self-care and mobility items at the time of admission. There needs to be at least, so in addition to that, there needs to be at least one goal completed for one of the self-care or mobility activities. And there is a column to document goals. And the goal documentation represents that there was a care plan and that the care plan included function. So when a resident is admitted, the therapists, the nurses would be doing assessments, writing a care plan based on the patient's full assessment, and would be setting goals. And so here's an opportunity to report the goal onto the MDS. The goals need to be scores 1 through 6, so we'll cover this in detail a little bit more, but it's using the same rating scale that was used to do the assessment on admission. And then the third component of the quality measure, so first step is the admission function data, second step is at least one goal, and then the third part of the measure is looking to see if there's complete discharge functional assessment data. And again, the rating scale is the same that we've talked about for admission as well as discharge. So step 3, we've covered the residents who had complete stays, and now we're going to look at the residents who had incomplete stays. So for step 3, we'll be looking at the Medicare Part A covered residents in the time frame who had incomplete stays. And for those individuals, those residents, we will be looking to see that the admission data is complete for the functional assessment items, functional assessment activities, and that at least one goal is reported for self-care or mobility items. Again, no discharge data are required when it's an incomplete stay for a resident. Step 4, we basically are adding together or summing the number of patients with the complete functional assessment data for the complete stays to the number of residents who have complete data for incomplete stays. So basically, the step 2 that I just discussed and step 3, those numbers are added together. In step 5, the numerator, which we just calculated from that sum, is divided by the denominator, and that count is multiplied, or that number is multiplied by 100 in order to turn it into a percentage. We'll go through an example in just a second, but I did want to clarify, first of all, there are no exclusion criteria related to this measure, and risk adjustment is not warranted. And the risk adjustment is not warranted because if it's unsafe for somebody to perform an activity, so for example, eating, if somebody has a swallowing problem and does not eat by mouth, perhaps they're getting food via G-tube, then you would just document that the activity did not occur. So all we're looking for are the valid codes or a valid 1 through 6 code from the rating scale or one of the valid codes indicating the activity did not occur. So just again, an example to kind of make this a little bit more concrete. So nursing home A has 225 residents that meet the inclusion criteria, so 225 residents who are covered under Medicare Part A during the 12-month time period. So in that case, that is the denominator. Again, there's no exclusion criteria, so the denominator is 225. Next, you need to know the number of residents who had complete stays. So of these Medicare Part A residents, let's say in this particular example, so this is just made up numbers, 165 had complete functional status data and at least one self-care or mobility goal and complete discharge functional status data. So complete stays, there's 3 things that we're going to be looking for the quality measure calculation. Admission data complete, at least one self-care or mobility goal, and complete discharge functional assessment data. In this case, we have been told here that among the 175 records, 165 met all 3 of those criteria, and so 165 is part of the numerator for the complete. So now we need to move to how many incomplete stays were there and how many among those residents is there complete admission data and at least one self-care or mobility goal. So in this case, we're given in the second bullet that there were 50 residents who had incomplete stays that were Medicare Part A and discharged during the time frame. And of those residents, 45 out of the 50 had complete admission functional assessment data and at least one self-care or mobility goal. So we're going to actually sum together the number of residents in this data set that have complete data as required by the complete stays, which is 165, and then the incomplete stays, which is 45. So the numerator now, we have determined 165 plus 45 is 210. The numerator, which again, we just determined to be 210, is divided by the denominator. The denominator we had several slides ago was 225. So somebody nicely gave us the result here, 0.993. And then we're going to multiply 0.993 by the 100 just to turn it into a percent value. And so we come up with the QM score, quality measure score, for this fictitious facility to be 93.3. Again, there's no risk adjustment because you will be able to code that an activity did not occur, and that counts towards the complete functional assessment data. So actually, I'm going to stop here to see if there's any questions, because I'm going to actually start talking about the actual activities and the scoring and all that, but I think this is a good opportunity to kind of stop and make sure that this is clear. Yes, question?
Yes. What if the stay is less than 3 days? Is it excluded?
So there is, so just to repeat the question, if the stay is less than 3 days,
Yes.
Is that excluded? So I need to look at the specifications to be absolutely sure, and I don't know, Roberta, or if somebody, let me get back to you on that. I do know for some of the quality measures, length stay of less than 3 days is an exclusion criteria, but I want to be absolutely sure it's for the cross-setting. If the source document, in case you are asking, if you are interested in more specifications, that was published with the final rule last year. It was published in August, and there was a large document that actually listed out, how do we define emergency discharge? So, for example, a discharge to an acute care hospital. So it does list all of that. So I will, if I don't hear back from Roberta, I will let you know after break. I'll look that up. Thank you. Yes?
Can you go back to slide 16?
Yes.
It says there has 225 residents. So does that mean if I have a resident who has 3 Medicare Part A stays in a 12-month period, is that going to count as 1 or does that count as 3?
Excellent question. Okay, so her question, she has one individual who actually has 3 stays during 1 calendar year. Is that a fair kind of elaboration of your example? So yes, we do count stays. So if somebody has 3 or however many number of stays within the time frame of the 12 months, each stay would be included. So an individual resident can be included more than once. Yeah. Other questions? Okay. Yep.
Not really a question, but a recommendation. Related to incomplete stays, your definition of incomplete stays, it sort of aligns with the definition of an unplanned discharge. Because if you code it as an unplanned, you're going to skip, well, you're not going to do a Medicare end of stay assessment, right? The only thing that I see missing is an unexpected discharge. Not everybody is AMA. You know, there are residents who decide to go home. The physician says it's okay to go home, so it's not really against medical advice. And that part of the definition is missing, but it is included with the unplanned discharge definition. So I really think that the two definitions should align.
Yeah, so, okay, so just to repeat your comment feedback is kind of the relationship between unplanned discharge and incomplete stay. And in general, you're absolutely right, they are aligned. Basically, anybody who has an unplanned discharge does fit within the incomplete stay. So what we did as what CMS did as part of the data set is if you select the unplanned discharge, you're not going to actually see the function items. But there's also the patients who pass away, the expired data patients that are included here, and so it is a little bit more comprehensive of a group. So the function items are not included on the expired form, and we do, as part of the algorithm, which I mentioned before, when we're looking at the data, we actually do look for the against medical advice. If somebody is filling out the unplanned discharge form and it was against medical advice, then it'll be, you wouldn't have been, asked to provide the information there, but we will also, on that form, we will also look to see if against medical advice is reported on the planned discharge form. We will look at the whether the person was discharged to acute care on that form. And again, we need to actually make the quality measure specifications standardized across all of the settings. And in the long-term care hospital setting, they actually do have the planned and unplanned discharge forms. In the inpatient rehab facility setting, we don't have planned or unplanned forms. So we're applying the criteria uniformly across those three settings at this point because the measure is adopted into those three settings. And so we basically say anytime somebody's discharged to acute care, they're excluded from the measure calculation. So, over time, there might be some clarifications or that, but at this point, we had to have something standardized across all settings, and so we basically exclude anybody discharged to acute care.
Well, can I just then make a comment that, especially for everybody here and listening, is to follow the directions for coding the unplanned, which would automatically then gray out section GG, right? Yeah. I mean, it's because they don't match. I'm more concerned about that resident that says, I want to go home tomorrow, right? And the doctor says, okay, set him up with home health, let him go home tomorrow. It's not AMA. The doctor is giving us a discharge order, but it is an unexpected, unplanned discharge, which is missing from that definition of incomplete stay. So,
okay.
But I see what you're saying. I mean, so I guess the recommendation is for everybody that, follow the definition of unplanned discharge, which will automatically convert it to an incomplete stay because you won't be doing section GG.
Okay. Yeah, I'm not able to comment on the coding
Right.
of unplanned, planned discharge. That's not something that I'm comfortable, and maybe some other person from CMS might be able to address it. But basically, when we look at the data, we will look to see if it's an unplanned discharge. If it's an unplanned discharge, then it'll be considered an incomplete stay. If you mark against medical advice on a planned discharge, then that person will also fall into the incomplete category. So I'm hearing a little bit of noise. If you have questions, let me know and we can revisit this. But basically, the bottom line is, you're right, that if there's an unplanned discharge, the GG items are grayed out and that's appropriate. Stacy, did you want to add to it? Sorry. Sorry, just a sec. There's a lot of, obviously, decisions you're making when you're deciding what forms you're filling out.
Yeah,
Go ahead,
so-
Stacy.
So, even if they're leaving the facility and it's unplanned, they still have a. Can you hear me now? If they're leaving the facility and it's unplanned, they still have an over discharge requirement, correct?
If it's unplanned, it's not on the unplanned discharge form.
Okay, it sounds like there's a lot of great questions surrounding the unplanned discharge. And maybe what we need to do is just regroup, step aside in the briefing room and really work through to make sure that we're giving the consistent information based on the scenario involving an unplanned discharge. Okay?
Great. Okay, thank you. All right, okay. All right, then I'll continue. Oh, another, yeah.
I was just going to say, there's nothing on a discharge MDS that says is it AMA or other than unplanned.
Yeah, right. So I think that was this gentleman's point, that it would be
There's not an item.
unplanned.
that-
Yeah,
so.
thank you. Okay, so now we'll move to going through the items, section GG items, which is called functional abilities and goals. So again, this relates to the Impact Act of 2014 that Stacy and Sharon talked about yesterday, and it requires CMS to implement cross-setting quality measures and the items in section GG that are required to calculate this measure. So if you look at the inpatient rehab facility, patient assessment instrument, the long-term care data set, all of the items that are included in the section GG of the MDS are also included on those data sets. So these items assess the need for assistance with self-care and mobility items. The items focus on the resident's self-care and mobility status at the time of admission. So there's an admission performance assessment. There are discharge goals that are reported and discharge performance. And I should clarify, I know in your settings you may have residents who are covered under the Part A stay and then go to convert to be on the nursing facility side. When I talk about discharge goals, I'm talking about goals at the time of discharge from the Part A stay. So they might be considered short-term goals. So a common question that we've had that has come up is related to which staff members can complete this section of this new section of the MDS. And so the response is that first and foremost, you need to refer to facility, federal, and state policies and procedures to determine which staff members can complete an assessment, because this is an official assessment, and as you know, there are state and federal and professional guidelines in terms of assessments. So as resident assessments are to be done in compliance with facility, federal, and state requirements. Based on our experience in the post-acute care payment reform demonstration, as well as other data collection that we're aware of in the skilled nursing facility, physical therapists, occupational therapists, speech-language pathologists, as well as nurses are typically the staff who are involved in the collection of the self-care and mobility items. One of the definitions that's important to cover related to section GG items is the definition of a helper. So for the purpose of completing section GG, a helper is defined as facility staff who are direct employees and facility contracted employees. So that would be the rehabilitation staff as well as nursing agency staff if you have agency staff. It does include individuals hired. It does not include individuals hired, compensated, or not by individuals outside the facility's management and administration, such as hospice staff, nursing, CNA students, and other individuals like that. Therefore, when a helper assistance is required because of a resident's performance is unsafe or of poor quality, only consider facility staff assistance when scoring the amount of assistance provided. So we'll be going through examples as we go throughout the day here. So if you actually look at the MDS form, and within your packets, you actually do have a copy of the section GG items. We'll be using that later on when we have the case study. You'll be asked to fill that out. But I did want you to maybe look at the form at this point, and it's exactly what you see on the slide. In terms of the section that is on the first page is self-care. There is the rating scale that's provided to you, the 6 through 1 scale. We'll be going through that in a few slides. On the right side, you will see the 3 codes that can be used if an activity was not attempted. So those are the 7, 9, and 88 codes. Again, we'll be going through those in a few minutes, but did want to let you know where they're written down. The actual items that are coded, so on self-care you have eating, oral hygiene, and toileting hygiene. And what you'll notice is there's actually 2 columns on the admission form. The first column is where you put admission performance, and then in the second column is where you put the discharge goal. On the discharge form for self-care, you'll see a similar layout in that there's information about the rating scale, and then you will see there's only 1 column here where you report the discharge performance. So again, the goal that was put on the admission assessment relates to the end of the Part A PPS discharge, and now here we are at the end of the SNF PPS stay, and this is where you mark the status of the person at the end of the stay. So a little bit of background in terms of why the function items are included in section GG as they are. So during a Medicare Part A SNF stay, residents may have self-care limitations at the time of admission, and they are, because of these limitations, at risk for further decline in function, self-care, and mobility during the SNF stay. So in terms of the steps, in terms of the assessment, so you would assess the resident's self-care status based on ideally direct observation, but it can also be the resident's self-report if the resident is able to describe to you their status accurately. You can also take into account family reports, what direct care staff report, and document in the resident's medical record. There is a 3-day assessment time period, which is days 1 through 3, and it starts with the date, which is the start of the most recent Medicare stay, which is reported in A2400B. Residents should be allowed during the assessment to perform as independently as possible, as long as they're safe. So if somebody is maybe in a hurry to get to therapy, and so somebody maybe feeds that person, so the person is not allowed to perform the activity of eating as independently as possible. Maybe they're a little bit slow, and so on this occasion somebody feeds the person, then that would not be considered an assessment. So we really need the resident to be able to do the activity as independently as possible, so it is an assessment. The third step in the assessment is if the helper assistance is required because of the resident's poor performance, maybe the person is unsafe or it's of poor quality, only consider staff assistance scoring according to the amount of assistance provided. Activities may be completed with or without assistive devices. Use of an assistive device to complete an activity would not change somebody's score to go up or down. So if somebody walks, so when we get to mobility, we'll talk about walking. For, let's say, eating, in the area of self-care, if somebody uses a universal cuff, or, for, let's see, for oral hygiene, they have some kind of special device they use to get the toothpaste out of the tube, so they can do that independently, then the use of those devices does not affect the score. If somebody's independent with the device, then they are independent with the device. If they are needing, let's say, partial assistance with the device, then that person is scored partial assistance. So we score or code the residents based on actual assistance provided, whether or not they use devices. Residents should be coded performing activities based on their usual performance, or their admission baseline assessment, which is identified as the resident's usual activity performance for any self-care or mobility activities. Usually when a resident is admitted, maybe a new resident is admitted to your skilled nursing facility, it might take a bit of time before they get used to the staff, and they are maybe starting to get therapy pretty quickly, so they might actually have some improvement in function. We're really interested in the person's status as they are admitted into your skilled nursing facility. And so oftentimes, if you're observing the person over multiple episodes, so for example, eating, somebody will eat multiple times during one day, they'll be getting perhaps in and out of bed multiple times during the first few days. And so if something does occur, an activity occurs more than once, and it is an assessment, then it won't be necessarily the most independent performance or the most dependent performance, but really kind of their usual status. But we're really after the admission status as they enter the facility. Refer to the facility, federal and state policies and procedures to determine which staff members may complete an assessment. So we've covered this a little bit, but resident assessments, as I said before, need to be done in compliance with facility, federal, and state requirements. So in terms of the more specific instructions and the coding, so as we were kind of mentioning before, you complete only these items only if A0310B is equal to 1, and that means that it's the PPS 5-day assessment, or if AG310G is a planned discharge. You would also complete it if A0310H equals 1, which is the Part A PPS discharge. So again, if the patient passed away, or if it's an unplanned discharge, you would not be seeing these items. So the rating scale I wanted to cover next, so you can either look at this on your MDS document in your packet or on the slides. We'll be going through each level one by one. So independent is coded 6, and it's defined if the resident completes the activity by him or herself with no assistance from a helper. So again, all of the definitions that I'll be going over in the rating scale all relate to assistance from another person, a helper. Hence, we gave the definition of a helper earlier. The activity can be done with or without an assistive device. It doesn't affect the score. It's just how much human assistance or how much helper assistance was required. So the next level is level 5, and because there's 2 spaces in the MDS form, you actually code 05 in this case for setup and cleanup assistance. And this relates to if the helper provides setup or cleanup assistance, and then the person actually, or the resident is able to complete the rest of the activity after somebody has set them up. So we'll be going through examples as we go along, but in general, eating, an example would be that the resident is actually able to eat on their own, but somebody maybe has to open containers or cut up meat for that person. So a helper in this case assists only prior to or following the activity. So prior to would be setup, and following would be the cleanup. But the person is actually able to eat by themselves. So somebody, actually for the person to be scored a 5, basically the helper can walk away while the person is eating. The next level on the rating scale, so we've covered 6 independent, we've covered setup, cleanup. The next level is level 4, which is called supervision or touching assistance. In this instance, for level 4, the helper provides verbal cues. Touching or steadying assistance is also included at this level, and this is done as the resident completes the activity. So if it's oral hygiene, I'll pick as this example. So if the person needs verbal cues or instructions to complete the activity, and it doesn't matter why the person needs verbal cueing, but if they require verbal cueing from or instructions from a helper, that would be coded 04. Assistance may be provided throughout the activity or intermittently. The next level is level 3, which is called partial or moderate assistance. If the helper does less than half of the effort, this is the correct code. And in this case, the helper provides lifting assistance, holds or supports the trunk limbs, but provides less than half of the effort. So just to kind of recap the levels so far, level 6 is independent, level 5 is setup or cleanup assistance, level 4, there was either some verbal instructions, nonverbal instructions, or steadying as the person performed the activities. Steadying is often done as part of mobility activities, but also could be part of the toileting hygiene. And then now we're down to level 3, where the helper is actually assisting the resident with performing the activity, whether it's walking or toileting hygiene, and the helper is doing less than half of the effort. So the resident is doing more than half of the effort. Level 2, we're now down to substantial maximal assistance, and in this case, the helper does more than half of the effort. So the resident is doing less than half of the effort. So the helper is doing most of the work. The helper in this instance is lifting, holding the trunk or limbs, and provides more than half of the effort. And then finally, level 1 on the rating scale is called dependent. In this instance, this is coded if the resident does all of the effort, if the helper does all of the effort, in this case, the resident does none of the effort to complete the activity, or if the assistance of 2 or more helpers is required, that will always be coded level 1 because there's a lot of resources required in order to have 2 or more people help one person perform one activity. As I mentioned previously, we know that sometimes a resident may not be able to perform all activities for various reasons, medical issues, or in some cases, a resident may refuse to perform an activity. And so we give you 3 codes that can be used to describe the reason that an activity was not attempted. So the first option is to say that the activity was not attempted because the resident refused to perform the activity, and that would be coded 7. The second option under the activity not attempted codes is 9, not applicable, and 9 refers to a resident did not perform the activity prior to the current illness, exacerbation, or injury. And I do need to give an example of this because we usually do get quite a few questions about this particular category. So we have some walking items under mobility, and we've had a question that came in that the individual, let's say, was perhaps had some paralysis, spinal cord injury, and the person was using a wheelchair and was not walking. And then let's say the person had a medical issue that brought them into an acute care hospital to get treated. Perhaps it was a pressure ulcer and some infections. And then they came to the skilled nursing facility for additional care. And so in this instance, the person was not walking prior to the current event, injury, or illness or exacerbation. And so in this instance, that would be coded 09. Well, I think we have some examples on this, and we can certainly answer some questions later on just to reinforce this. And excuse me, and I can definitely talk about this as we go through some of the examples that this may or may not be the correct code. Last code, which is actually the reason that you will code most often when an activity is not attempted, is code 88, and this is not attempted due to medical condition or safety concerns. So if the activity was not attempted because the person, let's say for eating, the person has a swallowing problem, the speech-language pathologist has determined that it's not safe for the person to eat, the person only relies on G-tubes, eating in this instance would be coded 88. If somebody had a new onset, let's say paralysis, and was unable to walk due to new onset paralysis, then walking would be coded 08, not attempted due to medical condition or safety concerns. So the difference between the two examples I just gave was in the previous example, the person had a long-standing spinal cord injury and was not walking prior to the current event, illness, or injury, so they met that criteria. In this instance, the person was walking prior to the current injury. Perhaps they were in a car accident, and so the person had some paralysis, and they were admitted to acute care and then your skilled nursing facility, so they're not able to perhaps walk on admission because of the current new medical condition. So 88, not attempted due to medical condition, would be the correct code. Okay, so wanted to spend a little bit of time kind of helping you think through how to code. So we found that it has been helpful for clinicians to kind of hear the thinking on how to get from a 6 or whatever the appropriate code is for the patient or the resident to code. And so this is just meant to help you kind of think through some examples. So as you go through maybe the case study or you go through some of the examples, here's kind of some thinking you can do. So you'd first of all start off saying, does the resident need assistance from a helper to complete a self-care activity? And help assistance, I need to clearly define here so that it's consistent with our definitions. Assistance from a helper here would be physical assistance, verbal assistance like cueing or instruction. It could be nonverbal cueing, so maybe somebody has a swallowing problem and you just have to do a visual cue to remind them to do a double swallow, or maybe just have to point to them or something. So if you have to be there to give some kind of instruction or a reminder, that is considered help. So any kind of cueing, or if there's setup or cleanup assistance. So if the answer is no, there's none of that assistance required in order to perform, to have the resident perform the activity safely, then the code would be 6, independent. If the answer is no, then we'll have to go down to the next question, where the next question is, does the resident need only setup or cleanup assistance from one helper? If the answer is yes, then you would code 5, setup or cleanup assistance. If the answer is no, then we need to go to the next slide and answer the next question, which is, does the resident need only verbal or nonverbal cueing or steadying or touching assistance from one person? If the answer is yes, then the correct code is 4, supervision or touching assistance. If the answer is no, then we need to go to the next question, and that is, does the resident need lifting assistance or trunk support with the helper providing less than half of the effort? If the answer is yes there, then the correct response would be 3, partial moderate assistance. If the answer is no, then we go to the next question, which is, does the resident need lifting assistance or trunk support with the one helper providing more than half of the effort? If the answer is yes, the code is 2, substantial maximal assistance? If the answer is no, then we're down to one more code for the rating scale, and that question is, does the helper provide all of the effort to complete the activity, or is the assistance of 2 or more helpers required? If the answer is yes, then the code would be 1 dependent. Just to revisit the activity not attempted, if the resident does not perform an activity, then we're asking you to help us to understand why the activity did not occur. The 3 options are 7, the resident refused; 9, not applicable, if the resident did not perform the activity prior to the current illness, exacerbation, or injury; and code 88, not attempted due to medical condition or safety concern, is coded if something is unsafe for the person to perform. So I wanted to spend a little bit more time going through some kind of more detailed coding tips. Most of these are in the training manual. So just for reinforcement, you have on admission a 5-day PPS assessment, which is coded as A0310B equals 1, and that is the first Medicare required assessment to be completed when the resident is admitted under SNF Part A. On the Part A PPS discharge assessment, so that's when you code A0310H as 1, the self-care and items, which are GG0130, are completed only if the discharge type is planned, A0310G equals 1. So that builds on what I mentioned earlier. When reviewing the medical record, interviewing staff, and observing the resident, be familiar with the definitions of each activity. So as part of the training today, we'll be going through each definition and going through at least one example for each activity. So examples of activities are eating, oral hygiene for self-care. For example, when assessing eating, item GG130A, determine the type and amount of assistance required to bring food to the mouth and swallow once the meal is presented to the person on the table or tray. When coding the resident's usual performance, use the 6-point scale or code the reason why the activity was not attempted. At admission, when coding the resident's discharge goals, so, we've talked about admission performance. Now we're talking about goals. So for goals, it didn't make sense to say that a goal would be that the person would refuse to perform an activity. So you can actually only code 1 through 6 as goals. And again, for the quality measure, a minimum of 1 goal is required to be completed, but it has to be one of the 1 through 6 codes. Record the resident's usual ability to perform an activity such as eating. Do not record the resident's best performance and do not record the resident's worst performance, but rather record the resident's usual performance during the assessment period, which is 3 days. Do not record the staff assessment of the resident's potential capability. We do want actual performance, not what the person could do if the toilet was, the other way and the bed was in a different position and the room was bigger. Just score what actually happens. That's the best estimate of the person's ability. If the resident does not attempt an activity and the helper does not complete the activity for the resident, code the reason the activity was not attempted. So just a clarification point here, if the helper does the activity for the person, such as feeding the person or brushing the person's teeth or cleaning the person's denture, then the code would be 1 dependent because the helper did the activity for the resident. The codes 7, 9, and 88 are only used if the activity was not done. I hope that makes sense, and we'll again go through some examples. If 2 or more helpers are required to assist the resident to complete the activity, code 1 dependent. We've had quite a few questions submitted related to this particular issue. So we've had the example submitted that says, okay, let's say for walking, We have one helper who is providing touching assistance to the resident as they walk down the hall, and we have another staff person who is actually following closely behind because we're not sure if the person will actually be able to walk a long distance. And so a second helper, in this case, maybe it's another nurse or a therapist, is following the person with a wheelchair. And let's say that that is what the person's status is. People are really concerned about the distance the person's able to walk. And so one person is providing touching assistance, but a second person is needed to follow in that wheelchair very closely behind. In that case, the assistance of 2 people is required, and so the code would be 1 dependent. So basically, anytime 2 or more people are needed, it's going to be coded a 1. I guess the other examples that we've had is, the person does a little bit of effort, so do they not get credit for that? So if by discharge the person is able to walk and the second person is not needed to follow in the wheelchair, and let's say they just need that steadying assistance, their score would go up to a level 4 by discharge. So the last point, I think we've covered a little bit to clarify your own understanding of the resident's performance of an activity. Ask probing questions of staff about the resident, beginning with general and proceeding with more specific. So if you're relying on perhaps some certified nursing assistants who have assisted the person during daily activities in the morning or in the evening, you might be interviewing them. And so we have some examples in the training manual, and we have a couple of examples in the slides where somebody is being interviewed, and you'll see that the nurse starts by asking a general question and then kind of wraps up with getting more specific and able to get details in order to score an activity. In the next, we've got about 5 minutes, I think, before break. So just wanted to bring up coding of DASH, and I would imagine we will get questions about this, so this will just be the beginning. So coding a DASH in these performance activities indicates no information. CMS expects DASH use for the SNF QRP items to be a rare occurrence. Use of DASH for the performance items may result in a 2% reduction in the annual payment update. So this was discussed yesterday about the reporting of information being part of the SNF QRP requirement. If the person couldn't be assessed, just code the 7, 9, or 8. Do not put a dash if a person cannot perform an activity. So again, these codes of 7, 88, and 9 are really important, and don't put a dash if somebody does not perform an activity. Always think through, is it appropriate to put 1 through 6? If it's not appropriate to put 1 through 6 because the person did not perform an activity, then think through whether the person can be coded 7, 9, or 88. Based on our experience, the most common code is medical safety concern 88. So probably most of the time 88 will be coded. Okay, we have basically less than 2 minutes before the break, so I think this is a really good time to stop. And so Mark, right, I think, right, we're due for a break. Is somebody from the Econometrica team? Hang on a sec. So I think, are we due for a break? I think 10 o'clock, keep going. Okay, all right, we'll keep going. I'm sorry. The timer is telling me I'm out of time, but keep going till 10, is that? Yes, okay. All right, so we'll get into eating. Thank you for the clarification. So we'll get into going through the items and going through some case studies. Sorry. Okay, if you want to stand up quietly and stretch, please feel free to do that. Sorry. So for the next item, or the first item actually, is eating. So what I'll do for basically the rest of this group of items. I'll go through a definition. You can look at your MDS document, section GG, that's in your packet to see the definition, write any notes on it. If you have the slides, obviously you have the definition on your slides. So again, we'll be talking about the first column first, which is admission performance. After we get through each of the self-care activities, there's 3 of them on the MDS. We will talk about goals, and then we'll end up talking about mobility later. So the first activity is eating, and eating includes the ability to use suitable utensils to bring food to the mouth and swallow food once the meal is presented on a tray or table. If the person uses some kind of specialized or is required to eat specialized food or specialized, thick liquids because of a swallowing problem or modified food, then just code whatever the person is eating. There's no special codes that we take into account for the fact that it's modified food consistency. So, with some of the examples, I'll just be kind of going through and talking through. There's no polling. With some of the questions, there is polling. So everybody should have on their table the polling from yesterday. In this particular example, it is actually not a polling item, so we'll just talk through it. So Miss S has multiple sclerosis affecting her endurance and strength. Miss S prefers to feed herself as much as she is capable. After eating 3/4 of her meal by herself, Miss S usually becomes extremely fatigued and requests assistance from the Certified Nursing Assistants, or CNA. And the CNA feeds her the remainder of the meal. So if you think through, the questions that I mentioned before, she does need a helper, right? And is it just supervision or touching assistance, or is it more than that? It seems like it's more than that. And so the next question is the helper doing more of the effort, or is the resident doing more of the effort? So what do you think? How would you code eating for Miss S? Okay, I heard a lot of partial moderate, thank you. Somebody up front here was loud, thank you, perfect. So I agree. So for Miss S, eating would be scored 03, partial moderate assistance, and the rationale is that the certified nursing assistant provides less than half of the effort, so the resident was doing more than half of the effort, and that would be coded level 3. Excellent. So now we do have a polling item, and so let me just reinforce before I go through this example that the item eating includes eating by mouth as well as drinking and drinking liquids, and if the person is not eating by mouth, then the activity did not occur. I guess the other thing, just as a teaching point, if somebody eats by mouth and has a G-tube, they are eating by mouth, you can code eating. So you would indicate that the activity did not occur if the person was not eating at all. But if the person eats and uses a G-tube, they're eating. In this particular instance, we learn Mr. R is unable to eat by mouth due to a new onset medical condition. He receives nutrition through a gastrostomy tube, which is administered by nurses. So the whole G-tube is actually not a consideration for eating. We don't incorporate that into the eating activity. The eating activity is really eating by mouth. So if the person does not eat by mouth, you should be able to indicate that with one of the codes. So this is a new onset medical condition, so he was eating prior to this, and so now we have this situation where he's not eating by mouth. How would you code it? So press A if you think the correct code is 88, press B if you think the correct code is 2, Press C if you think the correct code is 3. Press D if you think 9 is not applicable. Okay, so polling has opened. We'll do a countdown. So it's a new onset condition, and he's not able to eat by mouth. And it's, let's say, due to a swallowing problem. Okay, all right, let's see how you did. 95% coded 88, not attempted due to medical condition. It looks like a few people coded 9, not applicable. So in this case, this was a new condition, so he did actually eat prior. So if that was maybe your interpretation, if the person had not been eating had not been eating maybe for years, then the 9 would have been appropriate. Given that it was a new condition, the code is 88. Okay. All right, so again, correct response is 88. Yeah? Okay, so question, so it's helpful to come to the microphone, but I'll repeat what you said, and you can correct me if I'm not getting this right. So she had a question about differentiating, I think, 88 and 09. So if, remember the code 09 is reported if the person did not perform the activity prior to the current event, illness, or injury. So if the person was not eating prior to the current event or onset of the new condition, that let's say the person hadn't eaten, they've been on G-tubes for 5 years, then a 09 would have been an appropriate code. But this was a new onset condition, and the person is not eating now. And so they're coded 8, not attempted due to medical condition or safety concern.
So am I to understand that when we're considering what the patient's usual performance is upon admission, we need to take into account their prior level of function before this acute onset and hospitalization?
Okay, so the question is, do you need to take into account prior functioning? So prior functioning usually is something that is determined as part of admission.
Yes.
If you're needing to code these, either the 88, 07, or 09, it actually does make a difference. If the person was eating and they needed, partial assistance, then the prior functioning in this case wouldn't actually affect the coding. You just code what the person does. I should rephrase that. So if the person had, let's say the person's had a stroke, 3 years ago, let's say they were, needed setup assistance or something. Maybe they just had some fine motor problems, so they were setup assistance. They're admitted now to the SNF, and they need partial assistance, so they need a little bit more help. You code the help they actually need at this point in time. So you're right, you do take into account prior functioning, but you just code them based on their current status.
So if we're going to code someone as a 9 or an 88, we do take into account prior level of function. If we are going to code somebody anything else, we do not take into account prior level of function. Did I understand you to say that, or have I got it backwards?
So I'll restate it.
Okay.
And maybe just to be clear.
And thank you very much. I know I'm kind of hammering this home, so thank you very much.
That's fine. I want to be clear. So if a person was not eating, they were only on G-tube feedings, and they're admitted to an acute care facility and then onto the skilled nursing facility. So you would, to code 99, the 9, you would have to say, okay, was this activity performed prior to the current episode,
Right.
I should say illness, injury, or exacerbation.
Right, because theoretically he did not eat before or after, so that's why it's not applicable. Because he wasn't eating at home, he's not eating here by the eating definition on Gigi.
Right, so the example I just made up, not this example, so the example I just made up, the person was not eating for whatever, 5-10 years, and then they've got a new stroke maybe that brings them in, and so now they're still not eating,
Yep.
they're still on G-tube, so an 09 would be coded because the person did not perform the activity prior to the current event, injury, or exacerbation. But if
Yes.
the person did not have they were eating either independently or not independently, but they were eating prior to the current injury, illness, or event. When they're assessed and they are determined that they cannot perform the activity, so the options are the person refused, it's not applicable, but we know the person did eat in this instance before the current event, injury, and so the code 88, not attempted due to medical condition or safety concern, is the correct response.
Got it. Thank you
Okay.
so much for going through that again.
All right, so the next activity is oral hygiene. And for oral hygiene, that includes the ability to use suitable utensils to clean teeth. If somebody does not have teeth, it would include cleaning the gums because we do need to still do oral hygiene, or the person should be doing oral hygiene. If the person has dentures, then that would be what's coded in terms of oral hygiene. So that would be, in the case of dentures, the ability to remove and replace dentures from and to the mouth, and manage equipment, soaking, rinsing, whatever the person does with their dentures. So we have another example here where we have Mr. W, who does not have teeth, and his dentures no longer fit him. So in this case, people are he is cleaning his gums. So Mr. W begins to brush his upper gums after the helper applies toothpaste onto his toothbrush. He brushes his upper gums, but cannot finish due to fatigue. So he gets started. The helper completes the activity of oral hygiene by brushing the back upper gums and the entire lower gums. So how would you code? So I'm just going to think through the algorithm with you. So a helper was needed, and it's more than setup. So setup for hygiene, oral hygiene, is like putting toothpaste on the toothbrush or bringing water to the bedside if that's what the person does. So it's more than that. So the question is, how much is the helper doing? So the helper is doing part of the upper gums plus the entire lower gums. The resident is actually doing just part of the upper gums, and so you need to decide who is doing more of the effort. If the patient is doing more of the effort, that would be coded 03. If the helper is doing more of the effort, that would be coded 02. So in this instance, the helper was doing more than half of the effort. Do you agree? Okay, so what code would you give the person? Maximal, that's right. So 02, substantial maximal assistance. So in this case, again, just to reiterate, the resident begins the activity by brushing, part of their upper gums, but then the helper has to do the rest of the upper gums plus the entire lower gums, and so the helper is doing more than half of the effort. So that's an 02. So we have a polling scenario, and we have included an example where the nurse is actually interviewing a CNA. So the nurse starts out very broadly and says, does Mrs. K help with brushing her teeth? And so the CNA provides a very broad general response. She can help clean her teeth. So then the nurse has to ask a more specific question, how much help does she need to brush her teeth? And this CNA replies, she usually gets tired after starting to brush her upper teeth. I have to brush most of her teeth. So again, think through the coding. And the only response categories are 1 through 6. So if you think the correct code is 5, press A. If you think the correct code is 4, press B. If you think the correct code is 2, press C. If you think the correct code is 3, press D. So I will open the poll and start the countdown and give you a minute to think about that. And please feel free to discuss amongst your table. Okay, you're almost done? What do you think? Okay, it sounds like it's quieting down a little bit, so I will go ahead and put the answer up. So it looks like 93% coded a 2. I do agree with that response. So a couple of people coded, let's see, 4 and 3. So in this instance, there's more than touching assistance. So if I can have your attention, sorry. We've got a break in just less than 10 minutes. So in this instance, just to clarify, the level 4, which is supervision or touching assistance, that would be basically instances where somebody is, let's say, helping somebody with toileting hygiene or helping somebody with walking, and there's just like somebody touching them. If somebody is actually helping with the activity and providing more than touching assistance, that's going to be lower than a level 4, either a 3, a 2, or a 1, depending on the amount of assistance. And then it looks like somebody maybe coded a 3. So in this case, the example did say that the helper was doing more than most of the effort, so that's more than half of the effort. And so that's why we coded a level 2. Okay, the last self-care activity on the MDS is called toileting hygiene. And in this instance, toileting hygiene is the ability to maintain perineal hygiene, adjust clothing before and after using the toilet. It could be also that somebody uses a commode, so it would be adjusting clothing before and after using a commode or a bedpan or a urinal. If managing an ostomy, it would include wiping the opening but not managing the equipment. So I guess just to kind of break this down in a little bit more into what it is, because I know in section G you have an item called toileting. I just want to reinforce that toileting hygiene is just very specifically 3 tasks. So when somebody goes to the bathroom, it is pulling down pants and underwear, if that's what the person's wearing, sweatpants or what regular pants and underwear. Cleansing after voiding or having a bowel movement, so perineal hygiene. And then the third task within this activity is pulling the pants, underwear back up. So there's the assistance related to toilet transfer is not included in this item, so just any assistance with getting on and off the toilet is separated from, it not considered when you code this. So it's really what assistance is required as the person basically, let's say somebody's in the bathroom, and so the person is pulling down their pants or underwear, or somebody is doing that for the person, and then somebody, probably if the person can do their own perineal hygiene, they will do that. They can, sit on the toilet and do that, or a helper will be doing it, and then after the person has used the toilet, somebody will be, or the person on their own will be pulling their pants up and down. So it's kind of managing clothing, the perianal hygiene, and then pants back up. So those are kind of the 3 things to think about here. So we have a coding scenario here that we'll go through together. And in this instance, we have Mrs. J now. Mrs. J uses a bedside commode. So as I said, it could be a toilet or a bedside commode. It's still appropriate to code if it's a bedside commode. The certified nursing assistant in this instance provides steadying, touching assistance as Mrs. J pulls down her pants and underwear. So Ms. J, let's say she's experienced a stroke, she has some balance problems, and so somebody is providing steadying, touching assistance so far. So there is a helper involved. So this is as she's pulling her pants up and down. She sits on the toilet. When Miss J is finished avoiding or having a bowel movement, the certified nursing assistant provides steadying assistance as Miss J wipes her perineal area and as she pulls her pants and underwear up without assistance. So in this case, the patient is getting steadying assistance as she pulls the pants down. She is getting steadying assistance, but she actually does her perineal hygiene on her own with that steadying assistance, and she pulls her pants and underwear up. So the helper doesn't actually help with the tasks of managing the clothing. The patient resident does that all on her own, but she does require steadying assistance for each of those three components. So I think I mentioned earlier that the steadying, cueing assistance could be done intermittently or throughout. So in this instance, she needed steadying assistance for all three activities, but theoretically, steadying even just for one of these tasks would have meant the steadying assistance would be the important thing to consider in scoring, and she would have gotten the same score. So what do you think the code is? Okay, I hear a lot of 4s, and I do agree with that. So again, toileting would be coded for supervision or touching assistance because somebody is providing steadying assistance. Rationale is, again, the steadying assistance, but not more than steadying assistance. The person pulled her pants down, somebody had to steady her so she didn't lean over too far. We don't need a fall. We don't need a fall with injury. And she cleansed herself and she pulled her pants back up, but again, somebody was providing steadying assistance. Okay, so we have a polling. So Mr. C has Parkinson's disease and significant tremors that caused intermittent difficulty for him to perform perineal hygiene after having a bowel movement in the toilet. He walks to the bathroom with close supervision and lowers his pants. So one of the things I want to point out here is walking to and from the bathroom is not taken into consideration, so just ignore that in this particular scenario. So in this case, it says, walking with close supervision, so we don't need to worry about that. He lowers his pants, but asks the certified nursing assistant to help him with perineal hygiene after moving his bowels. He then pulls up his pants without assistance. So let's just talk through what's important here. So we ignore walking to the bathroom. He lowers his pants. He asks the certified nursing assistant to help him with the perineal hygiene. So the certified nursing assistant does one of these tasks, and then he pulls up his own pants. So in this case, the helper is assisting with one of the components of toileting hygiene. So he's not independent. It's more than setup. It's more than steadying because somebody's actually helping him with the activity. And so you have to think through who's doing more than half of the effort. If the helper is doing more than half of the effort, then it's going to be a 2. If the resident is doing more than half of the effort, it will be a 3. So what do you think? Okay, so polling. If you think the correct answer is 5, code setup. Press A, sorry. If you think the correct response is 4, press B. If you think the correct code is 2, press C. And 3 would be D. I'll start the countdown. Okay, if you can wrap up, I think we're getting ready for a break. Okay, all right. Looks like 87% of people wrote 3, and I do agree with that response. It looks like couple people wrote A, which would be setup cleanup. So actually, the cleansing of the perineal, perianal area is part of the activity. If the helper is helping with part of the activity, it's going to be a 3, a 2, or a 1. So it's more than setup. An example of setup for toileting hygiene would be something like the helper passes a piece of toilet paper and then can walk away. Remember, setup refers to assistance given prior to or after the actual activity occurring. Looks like a couple of people maybe put 4 and 2. So the helper did more than half of the effort, so that's why it's not a 2, and it's more than just supervision. So hopefully that helps. So at this point, I think it's a good time to break. I've got 6 seconds left, and Mark is at the wings here. So we will pick back up talking about goals after the break, and Mark will tell us how long the break is. Okay, so we will reconvene. The slides are back up. So I'll let everybody get their seat. And we'll pick back up with goals. As Mark said, we welcome the cards with questions. I know a few of you caught me at the break with some excellent questions, and we can absolutely provide responses so that everybody benefits from your excellent questions if you submit them. So one of the ones, while we're waiting for people to sit down, one of the questions somebody asked is, do you worry about whether somebody is using mouthwash and flossing and all that, as well as brushing their teeth for oral hygiene? So, these are all the activities are meant to be whatever the person does. So if somebody does, gargle, brush your teeth, floss, you would take all of those things into consideration. If the person just brushes their teeth, then that's what you would consider as oral hygiene. We don't have, it's part of toileting. You do have clothing, so whatever the person is wearing is whatever you take into consideration. We don't worry about what they're wearing. I mean, basically, if somebody needs partial assistance with whatever clothing they're wearing when they go home, let's say they're being discharged and they're partial assistance, they'll need that level of assistance because they'll be wearing probably the same type of clothing at home. So we would say code whatever the person's preferences are in terms of performing the oral hygiene or whatever clothing they're wearing as part of toileting hygiene. So those are great questions, and again, please write them down and submit them to the Econometrica team. Anybody in a yellow shirt at the back of the room. We will get back to folks in writing. We'll probably post some FAQs, and I think Terry Mata mentioned yesterday that the training manual will be updated, and so we can definitely put some more examples in potentially. So there will be more resources, and thank you for providing these scenarios that are excellent and help us kind of refine the scoring examples for you. Okay, so far we have talked about the quality measure. We will definitely take a revisit on that after the lunch. We have covered the 3 self-care activities that are included in section GG, eating, oral hygiene, and toileting hygiene. What I wanted to cover next is the setting of goals and relate that back to the quality measure. And there were some questions that were submitted yesterday related to this, so I will address that also. If you look at the MDS document that you have in your packet, you will see on the admission assessment for GG, the first column is the admission performance, which we just spoke about. The second column is called discharge goal. So again, this particular information is necessary in order to calculate the quality measure because, as you heard earlier today, the quality measure is about doing functional assessment on admission as well as having function included in the care plan, and the documentation on the MDS that function is included in the care plan is that at least one goal related to function is reported. So when we talk about care plan, it really relates on the MDS side as whether you have at least one goal that is in the area of self-care or mobility that's reported on the MDS when it's submitted. I also want to be sure that I clarify that when I talk about a discharge goal in the skilled nursing facility setting, that's discharge for the end of the Medicare Part A stay. So just a quick example, if somebody is, let's say somebody experiences a hip fracture, they have an acute care stay, they're admitted to your skilled nursing facility under Medicare Part A, they are there, let's say, they're admitted October 1, 2016, and they're discharged, let's say, October 15th, 2016. The goal, and then let's say this person happens to have other things going on, and they stay in your facility, but they're discharged from Medicare Part A on I think I said October 15th. So it would be the goal for the discharge associated with the Medicare Part A stay. So it would be the goal for the October 15th date. So if the person stayed in the facility, your nursing home, on the nursing facility side, they switch pairs, and they were there for, I don't know, another 3 months, it's not related to that part. The goal is related to the Part A stay. So when I talk about a discharge goal, it's the end of the Medicare Part A stay for this particular situation. So hopefully that clarifies. Okay, so again, at least one goal, you are more than welcome. In fact, I think CMS would be very happy if you report multiple goals. You are able to put a goal in for each of the self-care activities. I did want to clarify that as part of the goals, you need to put in a 1 through 6 code. So it can be any of those codes, 1, 2, 3, 4, 5, or 6. It is 2 digits, so you have to have that 0 preceding the number. You will not be allowed to enter 7, 9, or 88. So you need to either put in a 1, 2, 3, 4, 5, or 6 for a goal. So in the first column, you can use those 7, 9, 88 codes. In the discharge goal column, you can only put in 1 through 6. So just a little bit of background on the discharge goals. So licensed clinicians can establish a resident's discharge goal at the time of admission based on discussions with the resident and family, professional judgment, and the professional standard of practice. Goals should be established as part of the resident's care plan. A minimum of 1 self-care or mobility item must be coded per resident stay on the 5-day PPS assessment. So again, this is on the admission assessment where there's the 2 columns. Clinicians may code 1 goal for each self-care or mobility item included in section GG at the time of the 5-day PPS assessment. With regard to the discharge goal, in some cases, the goal may be that during the SNF Part A PPS stay that the intent is that the person will be getting therapy and may improve in function. And so in that case, because we have a scale that has higher scores indicating more independence, in this case, the discharge goal may be higher than the admission performance code. So we have an example. If the clinician determines that the resident is expected to make gains in function by discharge, the code reported for the discharge goal will be higher than the admission performance code. The clinician for a medically complex patient may decide that in some instances that maintenance is the goal during the skilled nursing Part A stay. And so in this instance, it may be that the person with this medically complex condition is not expected to make progress to a higher level of functioning during the Medicare Part A stay. The clinician determines that the resident would be able to maintain function in this particular area. So the clinician would discuss functional status goals with the resident and her family. In this case, the resident is a woman. So it's discussed with her and her family, and they agree that maintaining function is a reasonable goal for this particular activity. So let's say it is eating. In this scenario, the discharge goal would be coded at the same level as the resident's admission performance score. In some instances, you may have an individual who is admitted, and that individual may have a progressive neurologic condition, in which case the person's function may be declining despite the care that's being provided. So in this instance, it's possible that the discharge code would be lower than the 5-day PPS assessment performance code. So just an example here, the clinician determines that a resident is expected to rapidly decline and that skilled therapy services may slow but not prevent decline in function. So in this scenario, the resident discharge goal is lower than the 5-day PPS assessment admission performance code. Okay. So at this point in time, we have a coding scenario that we'd like you to work on within your group. So in your packet on the right side sleeve, there is a, let's see, it is called the Skilled Nursing Facility Quality Reporting Training Case Study. And so what we'd like you to do is read through this scenario, and you can, I guess the first paragraph kind of gives the background, and that's the most helpful information in terms of background. And then we're going to be going through the coding for self-care. So you can kind of skip over some of the information on the second page. We'll come back to that later. Physical therapy long-term goals can be coded later. And then the occupational therapy assessment is going to be important because that's where I see eating, oral hygiene, and toileting hygiene are addressed. And so as part of the example, I want you to think through how you would code the MDS, both the admission assessment performance and the goals for GG 130 items. So eating, oral hygiene, and toileting hygiene. So let's see, so we'll spend about 5 minutes, or I'm sorry, about 10 minutes having you review this case scenario. Please feel free to write notes, and then we'll pick back up in about 10 minutes, and we'll go through coding for the admission performance for eating, oral hygiene, and toileting. And then we'll take maybe a little bit more time, and then we'll talk through the goals related to those areas. And feel free to talk amongst your group. So you're allowed to be a little bit noisy now. So you're sharing information, sharing ideas about scoring. Okay, about 5 more minutes. Okay, if you could maybe wrap it up 1 more minute. Okay, actually, it's quieted down. We will go ahead. All right, so we've got, I'll just briefly review the case scenario, and then right now we're very focused on the admission self-performance. We care about coding for eating, oral hygiene, and toileting hygiene, and so we will kind of skip over to the OT assessment shortly. So just briefly, Mrs. J is a 92-year-old female who lives alone in an apartment in a senior housing complex. When she did not arrive for an evening event at the community room in the housing complex, one of her friends was concerned. She was found lying on the floor for the apartment, moaning in pain and clutching her right hip. She told the manager that she fell on her way to make breakfast and had been unable to call for help. So they called 911. So she was admitted to acute care, and so then she ended up in the skilled nursing facility. So we'll revisit a little bit more about her, but what I wanted to do is focus on scoring for eating, oral hygiene, and toileting hygiene. So if you actually can go to page 3, that's where the relevant information is. So we'll come back to mobility, of course, after we've gone through the mobility items. And so just wanted to talk through the excerpt from the occupational therapy evaluation. So that's just almost halfway down the page. And it says eating. Mrs. J was able to feed herself after staff opened her containers and set up her meal. And the help that was provided was cutting meat and buttering bread. So what are your thoughts in terms of coding that? 5? Okay, so I agree. Setup would be the correct code in this instance. So I think I did give those examples, but setup for eating are things like cutting up meat, buttering bread, opening containers. So I agree the admission assessment in this case, based on the OT's evaluation, would be 05 setup. By the way, the case study and the answers and rationale will be posted after training, I believe, and all of the slides with the correct responses will be posted after training. So if you're worried about getting the answers, we'll be providing those to you later. Okay, the next item that we want to touch on for this particular scenario is oral hygiene. So it's a little bit longer, so I'm going to read through it. Mrs. J was able to remove her dentures from her mouth, rinse them, and then place them in the cup to soak. After mouthwash was opened for her, she was able to pour it into a cup and rinse her mouth independently. So don't get distracted by the word independently. It's in there just because sometimes that's how you see things documented. But remember, the definition of independent is very specific for what we're talking about. So pay attention, but also you'll be using some judgment as you think through how to code this. She was able to remove the dentures from soaking and rinse them but required assistance to open the tube of denture adhesive. So that's actually important. There's a helper involved here now. She was able to independently apply the denture adhesive and place her dentures back in her mouth. So let's talk through this again. So she took her dentures out of her mouth, rinsed them, and placed them in a soaking cup. So she did that all by herself. Somebody opened mouthwash for her. She poured it into the cup and rinsed her mouth. She removed her dentures from soaking and rinsed them, but then somebody had to open the tube of denture adhesive. And then she put her dentures back in. So the assistance that was provided in this case related to opening the mouthwash and the opening the tube of denture adhesive. So what do you think? How would that be coded? 5, setup, cleanup assistance. That's correct. So in this case, the words independent were there because you see that documented a lot in clinical records, but she does not meet the definition of independent because in order for the rating scale that we're using to be coded independent, you have to be able to set yourself up. And if this person went home, somebody would be needing to open up the mouthwash for her unless they figured out something to make her more independent, which is very possible. Different types of open containers can be done for when she went home potentially. And then the adhesive, somebody also had to open that. So at this point in time, she's set up. But if this was the admission assessment as it is, I'll bet the OT had some things in mind to help her become more independent. This does bring up the question that came up about is mouthwash included or not? And again, the answer is if that's what the person does, that's what the score is going to be based on. So if somebody uses mouthwash, flosses, and brushes their teeth, the assessment of oral hygiene would be all of those things. If another person just brushes their teeth, then the assessment of oral hygiene would just be that for that person. And then the last activity that we have under self-care, so you'll have to skip past the toilet transfer again. Toilet transfer, obviously an important activity. It just is not on the MDS data set. So the toileting hygiene, so it's not in section GG, I should say. So the toileting hygiene, Mrs. J was able to perform her own perineal hygiene after supplies were set up for her. So set up for perineal hygiene, I think I gave the example before, maybe passing somebody toilet tissue. So let's say that's what happened here. She required the assistance of one staff member to manage her disposable garment. So she's wearing, some kind of undergarment that is disposable. And she needed help from that one assistant to pull up her pants and underwear, both up and down. So I think I explained before, but maybe I should clarify because there were some questions that came up at break. So usually for toileting hygiene, we kind of think of there being 3 tasks involved, where pants down is the first thing that happens. That's kind of one task. And then perineal hygiene would be the second task, and then pulling up the pants at the end would be the third task. So usually we kind of think of those being split into, a third, a third, a third. And so in this case, it sounds like she did her own perineal hygiene, so she did about a third of the effort. As I read it, it looks like she required assistance from one staff member to manage her disposable garments, pull her pants and underwear back up and down. So how would you code that? A 2, I agree. Okay, so, yes. Maybe go closer to the mic. Yeah, I think if you go closer. Okay.
I'm just saying that it felt like it didn't make sense from one to the other. When you said we have to manage what it is they're doing at that moment, like you said, if they do mouthwash, then do the mouthwash. The paper doesn't say mouthwash. When we did toileting, we said you don't have to do what the paper says, do what they normally do. That was undergarment 2, and they have other things. Now it's 4 undergarment, pants, hygiene.
Okay, so just for clarification, the 3 components, there's 3 tasks that we kind of think through in terms of toileting hygiene. The first one being clothing up and down, which in this case happens to include the disposable underwear. So that would all be 1/3, that whole component. And then the perineal hygiene is 1/3, and then the pulling the pants, including the disposable.
So is it always going to be 3 no matter what for toileting?
It's going to be 3 tasks for toileting.
Hygiene could be 10 if that person has all the checks with it.
Oral hygiene can be more complicated if the person does multiple tasks within oral hygiene. Yeah, we can clarify this. Okay. All right. So, is this related to this? Oh, you're just fixing the mic. Okay, thank you. Sorry. Okay, so, all right, we are going to take questions after. So if you don't, okay. All right, so I'm going to skip ahead here. Oops, we actually have to go through goals, sorry. All right, so with goals, let's see, so the goals are listed on the next page. So it talks about on page 4. So if you can quiet down, sorry. So it says the occupational therapy long-term goals. So the therapist would be thinking through what would be the goal at the end of the SNF Part A discharge. And so the goal in this instance was listed, resident will independently set up and eat meals and snacks. So what do you think the goal is in this case? Well, it says, independently set up and eat meals and snacks. So I agree with that. The goal is 6 in this instance. Okay, next, number 2 is related to oral hygiene, and it says resident will independently complete her oral care. So how would you code a goal for her? A 6, I do agree with that. And then for toileting hygiene, it says she will complete toilet hygiene independently. So, okay, great. Okay. So again, the responses and rationale will be posted on the website in the future, the SNF QRP website. All right, so next we're going to move to mobility. And under mobility, again, we are using a 3-day assessment period. This is admission, again, that we're talking about. So that would be the start of the SNF PPS day. So this is, I think, on the second page in your packet or on the other side of your page. Similar to what we saw in self-care, the first column will be the performance score, and then the second column is a goal. One of the things that I wanted to point out early as part of this section is there is a third column here. So the third column is different, and that's why it's indented into being its own column, because there's unique codes that are used there. So one of the things that CMS was very, very aware of is they want to reduce burden where at all possible. And so in some cases, there was a decision made to have skip patterns. So you've seen this on, or gateway questions. So you've seen this on other items. And in this case, there are questions related to walking, and those need to be scored. And then there's questions about wheelchair mobility. So somebody might be walking, somebody might be using a wheelchair, or somebody might be not walking but using a wheelchair, or in some cases somebody might be walking and not using a wheelchair. And so we have these gateway questions that allow you to skip the items. So the first question is related to, does the resident walk? So you would indicate yes or no, and we'll talk through that when we get to that item, but I did want to let you know that it's not the 6-level rating scale that you're using there. There's also a question a little bit further along, Q1, related to whether the person uses a wheelchair. So if the person doesn't walk, then you are able to skip over the 2 walking items. If the person does not use a wheelchair, then you're able to skip over the wheelchair items. So on the discharge form, so if you look at the discharge mobility section, you will see that, again, this is for the end of the SNF PPS day. There's only, in this case, the 1 column for performance, and then the same gateway or skip pattern questions that were on the admission form. So again, no goals reported on this particular form. So the rationale for the mobility items is similar to what we saw with the previous self-care items. Here, the resident, many residents admitted to Part A SNF care may have mobility limitations, and they're at risk for further decline in function, and so function is an important part of an assessment. The steps for the assessment are consistent with what you heard about self-care. And so the assessment, again, it does have to be an assessment, so the same rules apply in terms of the staff that are clinically able to do assessments. So the assessment of the resident's mobility abilities is based on direct observation. You can also take into account self-report where appropriate if the person can provide accurate information, reports from the clinician, care staff, and family, as documented in the medical record. It's a 3-day assessment period where the admission day is day 1 and it ends on day 3. It starts, again, with the date reported in A2400B, start of the most recent Medicare stay. As with all the activities I previously described, this is an assessment, so the resident should be allowed to perform activities as independently as possible, as long as they are safe in performing the activity. If the helper assistance is required because of the resident's performance being unsafe or of poor quality, score according to the amount of assistance provided. Activities may be completed with or without assistive devices, so it doesn't affect the score going up or down. If they use devices, they can be coded any level, basically. In mobility, actually, I will bring up one quick example that has been a question that's come up. If, let's say for walking, somebody uses a walker and somebody has to bring the device to the person and put it in the correct position, or for wheelchairs, somebody has to put the wheelchair in place, put the brakes on, take the armrest off, get the footrests out of the way, then that would be considered setup assistance. So the assistance with devices is considered. The point about this, my mentioning this point is that it doesn't affect the score going up and down. You just look at assistance required to perform the activity, regardless of whether they use a device or not. If the resident's mobility performance varies during the assessment period, so during that 3-day assessment, report the resident's usual status, not the resident's most independent performance, and not the person's most dependent episode. Refer to facility, federal, and state policies and procedures to determine which staff members in your skilled nursing facility may complete an assessment. Resident assessments are to be done in compliance with facility, federal, and state requirements. So in terms of the discharge performance scoring, again, it's the 6-level rating scale that we'll be talking about first, and that's on the left side of the page. We will also be talking through, again, the codes of 7, 9, and 88. Because we're talking about mobility at this point, I'll just reiterate that the information is collected on admission and discharge. So on admission, it would be when A0310B is coded 1, where that's the 5-day PPS assessment. And then if it's a planned discharge, which would be A0310G equals 1 for planned discharge, and A010H1, which is the Part A PPS discharge. So starting off again with the rating scale, the code's level 6 is independent if the resident completes the activity by him or herself with no assistance from a helper. Level 5, consistent with self-care, it is setup or cleanup that would be coded level 5 if that's the only assistance needed by the resident. The helper assists the resident only prior to or following the activity, but not during the activity. Code 4 is used when there is supervision or touching assistance required. Again, the supervision, as with self-care, can include instructions, verbal cueing, nonverbal cueing. It can include all kinds of activities that a helper might be doing where it doesn't involve touching, such as instructions, and assistance may be provided throughout the activity or intermittently. It still would be coded 04. Level 3, the issue of partial and moderate partial moderate assistance would be coded if the helper does less than half of the effort, meaning that the resident is doing more than half of the effort. The helper in this instance might be lifting, holding, or supporting the person's trunk or their limbs, but again, the helper is providing less than half of the effort. Level 2 is coded if the person requires substantial maximal assistance. So again, the helper does more than half of the effort in this instance, or the resident does less than half of the effort. And then dependent is coded if the helper does all of the effort, or in this case, the resident does none of the effort to complete the activity, or the assistance of 2 or more people, or 2 or more helpers is needed for the resident to perform the activity. Level 7, or category 7, is also the same as for self-care, where the resident refused. So if the resident refuses to complete an activity, code 07. 09, not applicable, means that the resident did not perform the activity prior to the current illness, exacerbation, or injury. And code 88, which is the most common reason you'll probably be coding, an activity was not attempted. This is coded if the activity was not attempted due to a medical condition or safety concern. So some coding tips related to the assessment for mobility. So the 5-day PPS assessment is the first Medicare required assessment to be completed when the resident is admitted to the SNF Part A coverage, and that's where the admission performance is captured, as well as the discharge goal. On the Part A PPS assessment, Part A PPS discharge assessment, so that's when A0310H is coded 1, the mobility items are completed only if the type of discharge is planned. So that would mean that A0310G is equal to 1. When reviewing the health records, interviewing staff, and observing the resident, be familiar with the definition of each activity. For example, when assessing walking 50 feet with 2 turns, which is item GG0170J, determine the level of assistance required to walk 50 feet while making 2 turns. So that's one of the mobility items. On the 5-day PPS assessment, code the resident's usual performance using the 6-point rating scale, and code the reason that the activity was not attempted, which is the 07, 09, or 88 codes. Discharge goals, consistent with what I mentioned under self-care, you can only code 1 through 6 for the discharge goals for the mobility items, as well as self-care. On the Part A PPS discharge assessment, code the resident's usual performance using the 6-point scale or the reason that the activity was not attempted. Record the resident's usual ability to perform each activity. Do not record the best performance or the worst performance. We're really trying to get an idea of the person's status at the time of admission. Do not record the staff assessments of the resident's potential capability. Again, if the person had a little bit more endurance, they would do better. Well, you actually score what's actually going on so that we can get accurate and consistent information. If the resident does not complete an activity and a helper does not complete the activity, that's when the code 7, 9, and 88 come into play. If the activity, let's say it's wheelchair, if somebody is pushing the person in a wheelchair because they're learning how to maneuver their wheelchair but they don't know how to do it, a helper is performing that activity, that would be coded 1 dependent. If 2 or more helpers are required to assist the resident to complete the activity, code 1 dependent. To clarify your own understanding and observations about a resident's performance of an activity, if you're needing to interview some of the staff in order to collect facts in order to determine the patient's status, ask probing questions beginning with the general and proceeding to more specific. Again, I believe we do have at least one coding example for mobility, and there are definitely several examples in the manual for you. Coding dash is the same as what I mentioned under self-care. A dash indicates that you don't have information. So CMS expects dash use for the SNF QRP items to be rare. Use of dash for these items may result in a 2% reduction in the annual payment update. If the reason that the activity was not attempted, please code, if an activity didn't occur, please code the 7, 9, and 88 codes. Do not put a dash because you do have some information that the person perhaps was too ill to perform the activity or the person refused. So do not use a dash for those instances. Please take advantage of those 7, 9, and 88 codes, because when we're looking at the data to see if you meet the requirement for the complete assessment, a code of 7, 9, and 88 counts, because you're telling us, I determined clinically it wasn't safe for this person to perform the activity. So you have met the requirement in that case. If you put a dash, you're telling us, I'm not telling you, I don't have the information. I didn't even, think through whether it was safe or not. So again, for the performance at admission and discharge, if it's not safe, code 88, do not put a dash, please. Okay, I wanted to talk through the coding, scoring, just to kind of make sure that's all, solid in your mind as you head to lunch. So just to reinforce, because I know repetition is helpful. So the first question to get started is, does the resident need assistance? And that's any type of assistance, either physical assistance, verbal, nonverbal cueing, setup or cleanup assistance. So does the person need assistance to complete the mobility activity? So if we're talking about walking, does the person need any assistance with walking? If the answer is no, the correct code would be 6, independent. If the answer is the person does need help, then the next question is, does the resident need only setup or cleanup assistance from one helper? If the answer is yes, then you would code 5, setup or cleanup assistance. If the answer is no, then we're going to the next slide with the next question. Does the resident need only verbal or nonverbal cueing or steadying/touching assistance from only one person? If the answer is yes, then you would code 4, supervision or touching assistance. If the answer is no, because the person needs more help than that, then the next question would be, does the resident need lifting assistance or trunk support with the helper, one helper providing less than half of the effort? If the answer is yes, then the code would be 3, partial moderate assistance. If the answer is no, we will go to our next slide. Next question, does the resident need lifting assistance or trunk support from one helper with more than half of the effort being provided by that one helper? If the answer is yes, then code 2, substantial maximal assistance. If the answer is no, then we're down to our last question for the 1 through 6 coding, which is, does the helper provide all of the effort to complete the activity, or is the assistance of 2 or more helpers required for the activity to be completed for the resident? If the answer is yes, then the correct response would be 1, dependent. Again, if an activity is not attempted, indicate 7 if the patient refused, 9 if the person or resident did not perform the activity prior to the current illness, exacerbation, or injury, or code 88 if it was not attempted due to medical condition or safety concern. If you're concerned that, for example, the person is not able to weight bear on either legs, then it wouldn't be safe for them to walk, and so a code of 88 would be appropriate. Okay, so the first few items in the area of mobility relate to bed mobility. So there's just a few areas. Then we get into transfers, then we get into walking, and then we get into wheelchair mobility. So we will start off with the first bed mobility item, which in this case for the MDS is sit to lying. So sit to lying is defined as the ability to move from sitting on the side of the bed to lying flat on the bed. So we have a polling scenario, so get out your clickers for your table, because I will be asking you to provide a response. So in this scenario, in this example, we have Mrs. H. So Mrs. H requires assistance from a nurse to transfer from sitting at the edge of her bed to lying flat on the bed because she has paralysis on her right side, so maybe she had a stroke. The nurse lifts and positions Mrs. H's right leg, so there is absolutely a helper involved at this point, and the helper is actually providing some lifting assistance already. Mrs. H uses her arms to position her upper body. Overall, Mrs. H performs more than half of the effort. So, how would you code GG 170B, sit to lying, for Mrs. H? Code 5 would, if you think 5 is the correct response, press A. If you think 4 is the correct response, press B. If you think 2 is the correct response, press C. If you think 3 is the correct response, press D. So I'll give you a minute and I will start the timer. Okay, I'll give you another few seconds. Okay, are you about done? Okay. All right, so just kind of thinking through it. So the helper is needed. The helper provides some lifting assistance. The patient is doing more, it sounds like. All right, let's see how you did. Okay, 83% coded O3 partial moderate assistance. There were a few people who coded level 2. So in this instance, you know, when somebody is, I'm just going to go backwards here real quick here. So getting from sitting on the edge of the bed to lying flat on the bed, you know, she's got 2 limbs, 2 legs. The helper assisted with one of the legs, so she did one of her legs, plus she, you know, got herself down. And it did say at the end that she performs more than half of the effort. And so that's the reason that this ended up being a 3. So I would have gone down to a 2 if maybe the helper assisted with both legs. So then I think that would put me thinking that the helper was doing more than half, or I'm sorry, the helper was doing, more than half of the effort, and the resident was doing less than half of the effort. Okay, so the next item is lying to sitting on the side of the bed. So we did sitting on the side of the bed to lying, and now we're going in the reverse direction where the person's starting from lying in the bed and they get to a sitting position. So in this instance, lying to sitting on the side of the bed is defined as the ability to safely move from lying on her back or on his back to sitting on the side of the bed with feet flat on the floor and no back support. So we have an example that we'll talk through together. Miss P is being treated for sepsis and has multiple infected wounds on her lower extremities. Full assistance from the CNA is needed to move Mrs. P from a lying position to a sitting position on the side of the bed because she usually has pain in her lower extremities upon movement. So in this case, if you were interviewing the CNA, you would ask about assistance, and she would tell you in this instance, or maybe she's documented, full assistance. So how would you code GGO 170C? A 1? I agree. So one point about this example is the rationale for why, or the underlying reason why the person can't perform the activity is not something that we report. We just report how much assistance is needed. In this case, it happened to be because of pain, she wasn't able to assist the certified nursing assistant with the activity. And so in this instance, she's coded dependent. So the helper fully completed the activity of lying to sitting on the side of the bed for the resident. Okay, the next item, which is D. And I guess this has come up with questions sometimes. Somebody has looked at this list and said, how come you start with B and then you have C and D? Where's A? So the answer is that there is an item A, roll left to right, that was that's part of kind of the overall standardized data, standardized functional assessment items. That actually happens to be on the LTAC Care data set, but it's not on the MDF. So there actually is an item that's not included on your data set, but it is included elsewhere. So I just wanted to be sure you're aware of that. Okay, so sit to stand. So sit to stand refers to the ability to safely come to a standing position from sitting in a chair or on the side of bed. So if somebody is getting up in the morning, it would be, they're sitting on the side of the bed, and are they able to come to a standing position? If so, how much help do they need? If the person is sitting in a chair and they are rising up from the chair, it would be how much assistance they needed with that. As I said before, if an activity occurs multiple times, we want their baseline admission assessment, and you would be determining what their usual status is. So we just have one example to do together. So Mr. M has osteoarthritis and is recovering from sepsis. Mr. M transitions from sitting to a standing position with steadying or touching assistance from the nurse's hand on Mr. M's trunk. How would you code GGO 170D and why? What do you think? Okay, I hear a lot of fours. Does that seem right? Supervision, touching assistance? Okay, I do agree with that. So touching assistance and supervision would be coded 04. By the way, sometimes in clinical records, I've seen people differentiate between close supervision, distant supervision, and different ways of reporting touching assistance, like contact guard. If it's touching only, then those would, and the supervision, whether it's distant or close supervision, those would all be coded level 4. So I know sometimes clinical terminology, might have questions about that. Yeah, do you have a question specific? Yeah, so I'll repeat the question, but yes, please do go to the mic in the future. So yeah, in this case, it talks about providing touching assistance, including the trunk. If the person is providing more than touching assistance to support the trunk, then that would be coded level 3. The score would go down. So if it's just touching assistance, it's level 4. If you're really holding on to the person and preventing them from swaying, where it's really trunk support, that would be coded down to level 3. Okay. So the next activity is we're moving to the transfers. So there's 2 transfers that are on the MDS. So item E is chair, bed to chair transfer. So it could be getting from the bed to a chair or getting from one chair to another chair. So in this instance, it includes the ability to safely transfer to and from a chair, bed to a chair, and the chair could actually be a wheelchair if the person is mobilizing using a wheelchair. So we have one example to do together here. Mr. F's medical conditions include morbid obesity, diabetes mellitus, and sepsis, and he recently underwent bilateral above-the-knee amputations. Mr. F requires full assistance with transfers from the bed to the wheelchair using a lifting device. 2 certified nursing assistants are required for safety when using the device to transfer Mr. F from the bed to a wheelchair. Mr. F is unable to assist in the transfer from the bed to the wheelchair. How do you code him? Okay, that was good. That was somewhat easy, but I'm glad to hear a lot of ones. So yes, indeed. So a lift device was used, and 2 staff had to be there to safely maneuver him from one location to the other. And so the fact that 2 helpers were required means that it's automatically going to be a level 1. Excellent. Okay, so now toilet transfer. So we talked about toileting, which is, the managing the clothing and the hygiene. So now, obviously, getting on and off the toilet is really important, and so that's included and includes getting on and off a toilet or commode. So this is one of the polling scenarios, so if you can get your clicker ready, you will be asked to enter your code. So the CNA provides steadying, touching assistance as Ms. Z transfers onto the toilet and lowers her underwear. So lowering of the underwear we're not going to worry about here. Under toilet transfer, we're just worried that somebody's providing touching assistance as she lowers herself onto the toilet. After voiding, Mrs. Z cleanses herself and then stands up as the helper steadies her. So the standing up part, she required steadying assistance. Mrs. Z pulls up her underwear as the helper steadies her to ensure Ms. Z does not lose her balance. So this is a complicated example because Obviously, in reality, toileting hygiene and toilet transfers happen at the same time. We don't just have people go transfer on and off the toilet with their clothes on just to do it, unless somebody's being assessed and learning. But in this instance, we've got somebody who's really needing to go to the bathroom, and so what needs to be kind of teased out of what's written here is, don't worry about pulling the pants up and down, don't worry about the hygiene, but just as the person is getting on and off the toilet. So it says here, the CNA provides steadying, touching assistance as Ms. Z transfers onto the toilet. So that's important. So there's touching assistance. We don't need to worry about the cleansing. As she stands up, the helper steadies her. So that's more touching assistance that's being provided. And remember, touching assistance can be provided intermittently or throughout an activity. Same score. And we don't worry about pulling up underwear. So at this point, I think, the key pieces were, as she was lowering, somebody was steadying her. As she was getting up, somebody was steadying her. So what do you think her code would be? Switch the slide. Yes, sorry. So the correct responses, please indicate if you think it's 4, press A. If you think it's B, press 2. If you think it's 3, press C. If you think it's 1, press D, and I will start the timer. So again, you're doing toilet transfer. So at this point, don't worry about toileting hygiene, because we're just coding toilet transfer. Okay, I think things are kind of quieting down, so I will. Okay, so we have 100% who coded 4. Excellent. Awesome. I totally agree. All right, and it looks like I don't have to explain that one. But again, the slides with the answers will be posted on the CMS website in the future with the answers. Okay, so we have another example, or I'm sorry, this is the rationale, but again, it was studying assistance, and in this rationale, again, which will be posted, it does spell out that the toileting hygiene pieces are not considered. Okay, so now we get to these gateway questions, which allow you to skip over some items if they are not relevant for the resident. So the first question is, does the resident walk? So on the admission form, there's actually 3 options for you to code. So remember, for each of the activities, we have the admission assessment. We also have goals. So it's possible that you have the scenario that somebody walks, and that's fine. You would code that the person walks. But if somebody doesn't currently walk on admission, it's possible that they may be walking by discharge, and there may be a goal that you would like to enter related to walking. So there's actually 3 response options on the admission form. So it's a simple question, does the resident walk? If the answer is no, you actually have to clarify whether there's a goal of walking that's clinically indicated. So if you put 0, that means no, the person doesn't currently walk on admission, and a walking goal is not clinically indicated. So a physical therapist might determine that, let's say this person has had double below-the-knee amputation, and at this point, they are not fitted for prostheses at this point, and so maybe wheelchair mobility is the goal for this individual. So in this case, for that patient resident, the response would be 0, no, and walking goal is not clinically indicated. If 0 is selected for H1 on the admission form, then you would actually skip over to GG170Q1, which asks whether the resident uses a wheelchair or scooter. So you bypass the 2 walking items. For the quality measure, just so that you're kind of reassured, for the quality measure, remember we say that you have to code each of the self-care mobility items. If you tell us here that the person doesn't walk, then we actually know that walking would basically be coded one of the 88 codes probably. And so you're filling out this item allows you to skip over the J and the walk with 50 feet with 2 turns, the walk 150 feet, and we count the fact that you've told us the person doesn't walk as you've done the assessment. So the system, if you put a 0 code for no, the resident does not walk, then you won't be allowed to enter a code for either walking item. So if the person is, let's say somebody's had a hip fracture and they're admitted to your SNF, they're not currently walking, but the physical therapist does believe that the person will be walking by discharge. We want you to be able to write a goal related to walking if you choose to do that. And so you would actually, in that instance, code number 1 saying, 1, no, the person is not currently walking, but a walking goal is clinically indicated for this individual. If that is the case, then you can code that opens up the GG 0170 J and K goals for you to report goals for those 2 activities. So that's a big difference between coding a 0 and 1. You can enter walking goals if you code 1. If you enter a 0, you will not be allowed, because of the software specifications, you'll not be allowed to enter a goal for either walking item. If the person does walk, then you would code yes, and you would continue on to the item J, which is walk 50 feet with 2 turns, and you would also complete the walk 150 feet. So, quick example, just to reinforce this, Mr. Z currently does not walk, but a walking goal is clinically indicated. How would you code, whoops. How would you code, a 1. So, let's see, let me grab my, so, sorry, I'm looking at the discharge. So on the admission, so a walking goal is clinically indicated, so we would actually answer a 1. I agree with that. So, so the correct response is 1, and you would be able to enter discharge goals for walking 50 feet with 2 turns and 150 feet, and the rationale is that the person doesn't currently walk, but there is an expectation that they would walk potentially by discharge. So at discharge, so you're completing this at admission, but of course at discharge, we're trying to get another snapshot of the person's function. So at discharge, we don't have to worry about goals. And so what you'll see with this item, which is GG 170, it's now changed to H3 instead of H1 to indicate its discharge. So we just ask you, does the resident walk? If the answer is no, you would code 0. If the answer is yes, you'll code 2. So we kept the codes consistent, but of course the goals is not an issue, and so there's no 1 that can be coded at discharge. So we have another example at the end of her SNF PPS stay. So again, when I talk about discharge, I'm talking about the end of the SNF PPS stay. So this just reinforces that point for me and for you. Mrs. H is walking with a quad cane to all destinations in the facility and safely walks outside in the courtyard with her walker. How would you code GG 170H3? So does the person walk is basically the question. So what do you say? Yes, right. So that would be coded 2, and you are correct that that will allow you to code walk 50 feet with 2 turns and walk 150 feet. The rationale, she's currently walking. I have had some questions that came in about whether the admission assessment response of whether the person walks or not and the discharge response about whether the person walks or not has to be consistent, and the answer is no. On admission, you're giving us a snapshot of the person's status. At discharge, you're giving us another snapshot. It's very possible somebody was not walking on admission and they're walking by discharge, and that's perfectly fine. So if the person is walking, then you'll be asked to complete walk 50 feet with 2 turns. So this refers to, or this assessment starts once the person is in a standing position. As you may remember, we already talked about, getting from lying to sitting on the side of the bed. We already did sitting to standing position. We've talked about transfers. So in this case, the person's standing, and we're just asking, can the person walk 50 feet with 2 turns? We've had a lot of questions about what a turn is. So a turn for the this item, as well as the wheelchair item that'll be coming up shortly, it's a 90-degree turn. So it could be around a corner, into a bathroom, into the person's room. So it's 90 degrees. There are 2 turns. The 2 turns, which are 90 degrees, can both be in the same direction. So there can be 2 right turns, or there can be 2 left turns, or there can be 1 right turn and 1 left turn. I think I've covered all of the examples. So 2 turns, 90 degrees, and you can probably give me some examples this afternoon to go through. Okay, so we have a polling scenario, so get your clickers ready. Mrs. L is unable to bear full weight on her left leg as she walks 60 feet down the hall with her crutches and makes 2 turns, 2 90-degree turns. The CNA supports her trunk and provides less than half of the effort. So there's support that is happening. It's more than steadying assistance. And the helper, CNA in this instance is the helper, and she is providing less than half of the effort, which means that Mrs. L is providing more than half of the effort with her crutches. So, how would you code? If you think the correct response is 5, code A. If you think the correct response is 4, code B. If you think the correct response is 2, code C. If you think the correct response is 3, code D. So I will give you a minute to think through the coding. All right, so there's support of the trunk happening, and the helper provides less than half of the effort, in case you don't have that example right in front of you. Okay, you were ready? Okay. Okay, all right. 100% coding D. So I agree. So in this instance, the rationale, whoops. Okay, I don't have a rationale slide. In this instance, you're all correct that the resident was doing more than half of the effort. The helper, CNA in this instance, was providing more than touching assistance, so that's why it went down to a 3. Okay, so next we have walking 50 feet with straight walking 150 feet. So that can be in a hallway or a similar space. And it begins once the person is in a standing position, so that's consistent with the last item. So we have an example to go through together. Mr. R has endurance limitations due to heart failure and has only walked about 30 feet during the 3-day assessment period. He has not walked 150 feet or more during the assessment period, including with the physical therapist who has been working with Mr. R. The therapist speculates that Mr. R could walk this distance in the future with additional assistance. So,
I have a question. I'm sorry.
Oh, yeah.
For the previous question,
Yeah?
you specified there are 2 turns, but what if there were no 2 turns? A resident ambulated 60 feet, and that's it.
Okay, so there's a question at the microphone asking if the person can walk 60 feet but does not turn, how would you report that? The activity didn't occur because you do have to have 2 turns. So I guess I'm wondering if there was, like, if the person maybe had some serious balance problems, that's why the 2 turns weren't made, and then maybe it would be coded 88. So, but I mean, there is an expectation that the person would probably walk with 2 turns during the day. You know, we've one of the reasons we actually included this activity in the item set, and it was tested as part of the, if you can quiet down, sorry. So one of the reasons we included it is that people turn on a day-to-day basis, like all the time, and so one of the physical therapists who was part of our original team developing the item set talked about the importance of turns, and so the person does have to do 2 turns as part of walking 50 feet. If they don't do it, then you'd have to provide kind of a code to indicate why the activity did not occur. So
I
if it's
completely agree.
an 88 would be potentially a code.
Okay.
Yeah.
And another question is about the effort, because it's saying the resident was provided less than half of the effort, but let's say this patient needed that much effort through the whole task. So would that still be moderate as we scored, or would it be, because it was for the whole task, would it be then dependent? You see?
Okay, so I'm not sure I understand your
I'm comparing
question.
this example with previous examples, for example, eating. You know, Mrs. J was able to feed herself 75% of the time, but then the other 25% of the time she needed full assistance. So for that one, we coded max assist, correct? And then for this one, it is moderate assist needed for the whole task. So my confusion is the effort. How do you describe effort? Is it time-based, task-based, like a component, or it's the assistance level?
Yeah, so
The
we're
effort is-
worried. So we refer to these as activities, and then components might be like a task. I think, you know, in toileting hygiene, I talked about tasks within the activity. So in this case, walking 50 feet with 2 turns is the activity, and it says that she walks 60 feet in the hallway with her crutches, making 2 turns. The CNA provides trunk support and provides less than half of the effort related to the activity. Would that help if it said related to the entire activity as walking 50 feet with 2 turns? Is that what your question is?
I'm a physical therapist, so I'm providing moderate assist, let's say less than 50% of the assistance, but for the whole time, for 60 feet. You know, often patient needs that much or more. It never gets better, hardly ever, you know. So how would you describe that task? How would I grade that task?
So the person requires trunk support for the entire walking 60 feet with 2 turns? Is that?
Yeah.
So that I would code that still the same, that it would be a 3, that it's throughout the activity of walking 60 feet. So maybe you can write down your question more specifically, because I do want to be sure I get through all the material.
Okay, thank you.
But it's related to the entire activity. If somebody needs a little bit of help with one component, you know, that was kind of the toileting hygiene, so we took that into consideration of the entire activity. Okay, so let me just catch back up here. Okay, so I think we're here. So walking 150 feet. So in this case, the person was not able to walk 150 feet. We do have other walking items, and so in this case, we'd actually say that the walking 150 feet did not occur because she was not able, I think it was a she, the resident was not able to walk 150 feet, and so the activity did not occur, would be coded 88. Next, we're moving to the wheelchair. and actually it's wheelchair or scooter. So if somebody uses a scooter or a wheelchair, they would both be coded within this next set of items. So the first question is basically a gateway or screening question. If the person doesn't use a walker or a wheelchair, you can bypass the next few items. So the response categories are that the person does not use a wheelchair or scooter. In that case, the code is no. A 0 is coded, and then you're able to skip over to the next items. If the answer is yes, that the person does use a wheelchair or scooter, then you're able to continue on with the wheelchair. And in this case, the first item is wheeling 50 feet with 2 turns. So we have the same item on the admission assessment and the discharge assessment. So if, again, a discharge, the person maybe was using a wheelchair on admission, but they no longer use a wheelchair at discharge, you would just code whatever is happening at that point in time. It's possible they're coded using a wheelchair on admission, but don't use one at discharge, and you would just code that they don't use it at discharge on the discharge form. There's no need to have the same code on admission discharge. So the first first activity is wheeling 50 feet with 2 turns. So this begins once the person is in a seated position in their wheelchair or scooter, and in order to be coded independent, the person must be able to wheel themselves at least 50 feet and make those 2 turns. Again, the turns are defined as 90 degrees. Could be turning into a room, turning into a bedroom, turning into a bathroom, turning around a corner, 90 degrees. It could be one to the left, one to the right. It could be 2 right turns or 2 left turns. Just 2 turns is necessary. So we have one coding scenario together. Do you have a question?
I do. I'm just trying to figure out if you're in a manual chair versus a motorized scooter, how could that be even comparable? You could have a resident that can roll 40 feet in a manual chair and be coded as substantial or max assist because someone has to assist with pushing the chair, and then you have another person, literally, that has the movement of 2 fingers that can push a motorized wheelchair and push to turn, and they can be independent.
Yeah. Yep. So we actually do, we're getting there, but so let me preview, and maybe you might want to submit a question or we can talk at the end. But we do actually ask as a follow-up question for each of the wheelchair items what type of wheelchair the person has. Whether, because I did mention scooter, but you're right, a wheelchair could be a manual wheelchair or a motorized wheelchair, and you're absolutely right that you could have somebody who basically has very, after maybe spinal cord injury, has in general low function, but they can actually maneuver a motorized wheelchair with very little effort with one hand, or there's some that are tongue driven. And so we actually do have you code the type of wheelchair so that we do have that information. So we'll get to it in a minute, okay? So what we're asking though is you score the amount of assistance that's required in order for the person to mobilize in the wheelchair or the scooter. So in this first example, again, it begins once the person is seated in the manual wheelchair, and Miss R wheels about 10 feet and asks the therapist to push the wheelchair an additional 40 feet into her room and her bathroom. So there's 2 turns happening. It may not be obvious, but there's 2 turns happening when she goes into her room and into her bathroom. So the 2 turns is covered. What's important in this particular example, and I think this relates to the question that came up before, how do you think through the coding and the effort? In this instance, the person wheels 10 feet, and then the helper is actually going 40 feet. So in this instance, the distance is going to be, for the wheelchair mobility, how things get coded related to effort. So, and I think maybe that might be partly what your question was also about. So in this instance, you would code that the patient was doing some of the effort, so she's not going to be coded 1 because she did something, but in this instance, she was only able to go 10 on her own, only able to go 10 out of the total of 50 feet because the helper did 40 feet. And so in this instance, we would code her a 2, substantial maximal assistance. Another, I guess this also relates to what I was just talking about. So for the 2 wheelchair mobility items, there are follow-up questions so that we know whether a person was using a manual or a motorized wheelchair. So a scooter would be motorized, but a wheelchair could be either manual or motorized. And so again, this is that 3rd column on admission, the 2nd column on discharge. If you could just let us know the type of wheelchair, and a 1 would indicate that it's manual, a 2 would indicate it's motorized. The, let's see, I'm just doing kind of a time check. So let's see, I think I'm going till 12:30, right? I'm just looking for going till 12:30. My timer says I have 11 minutes, so I actually have another half hour after. Okay. All right, just getting different messages, so I just want to be sure. Okay, so again, you're coding type of wheelchair. 1 is motorized, or I'm sorry, 1 is manual and 2 is motorized. So the next item relates to wheeling 150 feet. And so in this instance, again, you start in a seated position in the wheelchair or scooter, and the person can wheel at least 150 feet in a corridor or similar space in order to be coded independent. If they do it on their own, they're independent. So we have an example to go through together. Mr. G always uses a motorized scooter to mobilize himself down the hallway, and the physical therapist provides cues during because of safety issues. Basically, the person is running into the walls, and so the therapist is providing some guidance to remind the person. Maybe the person's had a stroke and they've got some neglect, and so the therapist is providing some guidance so the person doesn't run into the wall. And so how would you code if there's verbal instructions, verbal cues or nonverbal cues being provided to this individual, either intermittently or throughout the activity? Okay, so I agree. I would code that a supervision. The category includes touching assistance, but in this case, it's the supervision that actually puts the person into that category. So as I indicated previously, for both of the wheelchair items, somebody might use a manual chair for one distance, but when they go for a larger distance, might use a motorized chair or their scooter. And so we do ask a follow-up question for both of them. Again, 1 would be coded for manual and 2 would be coded for the motorized wheelchair. Wanted to just touch on goals briefly. So basically, what I said previously about the self-care goals also applies to the mobility goals. So it's on the admission assessment, on the 5-day PPS admission assessment, and it is discharge referencing the end of the SNF PPS Part A stay, and only the codes 1 through 6 can be used. Oops. Yeah, so only 1 through 6 can be coded. You cannot use the 7, 9, or 88 for goals on either self-care or mobility. So you can reference back to the other slides if you have questions, and the information is repeated in the manual. Okay, so we are getting close to lunch, but we do have one last exercise, and it relates to the same scenario that you were reviewing for self-care. But of course, in this instance, we are going to be looking at mobility scores. And so if you can look at the Skilled Nursing Facility SNF Quality Reporting Program QRP training case study. And if you can review the items that relate to mobility and both the admission assessment and the goals. So I will give you about 10 to 15 minutes to go through and code those as a group within your group, and then we'll go through the answers together. Okay, I think another minute and we'll pick back up. Okay, I think we'll get started. So a few people have given me cards, that's fine. Please do filter the cards back to the Econometrica staff with the yellow shirts. But happy to take cards, so thank you for filling those out. And we will, I'll probably have a bit of time to take some questions at the right before lunch. And then I think maybe at the end of the day we can pick back up. I know we've got another speaker coming up after lunch. So we have about 30 minutes before lunch, so we'll spend a bit of time going through the case scenario. And it is Mrs. J. And I'm sure there was lots of interesting discussion. You know, these case studies were written by clinicians. They reviewed some medical records and basically wrote down what was in there. So sometimes it's kind of clear what's going on. Sometimes you probably wish you have more information. One of the other issues is that I think we had this with the other example. The word independent sometimes is used, but it doesn't meet our definition of independent. So you have to be careful about that. Have to be careful about definitions. In this instance, also, you had to look mainly to the PT assessment, but also to the OT assessment to get, let's see, it was the toilet transfer was written in OT, and that's reality. You have to dig sometimes to find the information that you're looking for. So kind of a realistic scenario was the intent behind this. So I guess we did go through Mrs. J a little bit, but I believe she had a fracture and she had some other things going on like pressure ulcer, anemia, and so basically we will kind of skip ahead to the physical therapy note to get an idea about her mobility skills. So if we were filling out the MDS section GG, the first question relates to lying to sitting. So in this particular document, they talk about sit to supine, but lying supine, same difference. Obviously, that's not a concern for us. We can still code this item based on sit to supine being in the notes. So it says here, Mrs. J required assistance of the therapist to bring both her legs back into bed as well as support her trunk. So would have been nice to maybe have a little bit more detail, but it sure sounds like the helper, in this instance it happens to be a therapist who's the helper, but there's lifting of both legs going on. There's some trunk support that's happening. What do you think? A 2? I agree with that. So, you know, it would have been nice to know that the resident actually did participate, but it sure sounds like the resident was participating because it was just trunk support. It wasn't a complete lift. But the fact that the therapist lifted both legs, plus provided some additional support as she kind of got into that supine lying position, the therapist sure sounds like she's doing more than half of the effort, so I do agree with that. The next activity is lying to sitting on side of bed. So on the case study, the next item down is about supine to sit on side to bed. So, you know, same difference, lying supine. So it says here, Mrs. J was able to bring her left leg off the bed. Okay, so she's, I'm just kind of picturing this. So she's moving her left leg. She allows it to go off the bed and assists with pushing up on her right arm. She requires maximal assistance to bring her her right leg off the bed. So there's some lifting that's happening. So you will sometimes see in the clinical record things like maximal assistance. That's used a lot in here. So that's kind of implying that there's a lot of help that the helper is providing. And then she needed to be supported by the therapist to come to a lifting position. So there's the resident, kind of got her own leg down, but then she needs definitely some lifting assistance with that second leg, and it was mostly done by the therapist. And then there was support that was needed, so it's more than touching assistance that was provided by the therapist to get from a supine to a sitting. So what do you think? A 2? I agree with that. It sounds like the resident did a little bit of the effort, but the therapist did more than half of the effort. Okay, next example, next item, sit to stand. Mrs. J was able to come to a standing position with maximal assistance of the therapist. Once standing, the resident used a hemi-walker to steady herself. Using a gait belt, the therapist had to partially lift and support Mrs. J in order for the resident to come to a standing position. So there's kind of this, maximal assistance, and then they actually describe it for us a little bit more, that there was lifting that was provided and support in order for her to come to a standing position. So the fact that the word maximal is there suggests to me that the therapist is doing more than half of the effort. It's, in combination with the other. So how did you interpret this? A 2? Okay. That's actually where I also landed in terms of scoring. So any questions about that? Okay. So the partial lift was a little bit vague, but then I kind of went back to that maximal assistance description, and that made me think that the therapist was doing more than half of the effort. So that's why I ended up with a 2, and it sounded like most of you did also. Okay, next activity is bed-to-chair transfer. So Mrs. J required maximal assistance from the therapist to pivot transfer to a wheelchair. So in this case, it sounds like it's, is she starting in bed here? Okay, I'm not sure if she's starting in bed, but she's getting into a wheelchair, and we've got the word maximal assistance written down. So now we've got some additional clarification. In addition to providing physical assistance with the transfer, Mrs. J needed the therapist to position the hemi-walker prior to and during the transfer and provide verbal cues. Using a gait belt, the therapist lifted and supported the resident during the transfer. So we know it's more than steadying assistance. We know there's lifting assistance, and the fact that the word maximal assistance is also documented. What do you think? A 2? Yeah, that's where I landed too. Okay, so now we have some additional items related to toilet transfer, and that was actually done by the OT. So, as I mentioned before, it doesn't really matter who does the assessment as long as it follows the requirements set by the facility, state, and federal regulations. So the OT in this instance describes toilet transfer. Mrs. J transferred on and off the toilet with maximal assistance of the therapist and use of a hemi-walker. So how did you code that? A 2? Okay, I agree. Okay, so then we have the question, does the resident walk? So under ambulation, we're back in the physical therapy note, and it says, not tested at this time due to safety concerns. Anticipate Ms. J will be ambulatory at discharge. So if you remember on admission, the codes for does the resident walk, the options are no walking, not currently walking, and walking goal is not clinically indicated. A 1 would be no, not currently walking, walking goal is clinically indicated, and 2 would be coded yes. So how did you code that? A 1. Okay, so I agree. Not currently walking, but a goal was clinically indicated. So because you are indicating that the person is not currently walking, You would not be allowed to enter codes for the 2 walking items in the software. Of course, on your piece of paper, you can write whatever you want. So in the system, you would actually skip over, so there's no response needed for either one of these. But if you did put a code, you probably put something like 88 related to safety or something. Yeah, so, I mean, essentially, when we recode, that's what we'll recode to say, so you're ahead of us. But the software, as I said, won't allow you to enter, so you would actually skip over. Okay, so then the therapist did evaluate the person in terms of wheelchair mobility. And actually, I do want to bring up this issue related to wheelchair mobility. So are there, questions? Happy to address them. If you code that the person is not currently walking, but there are goals indicated, you are allowed to enter goals. The requirement for the quality measure is that you report at least 1 goal, so you could choose to put a walking goal. If you have goals for all the activities, then you would be entering for all of them. Okay, so I wanted to bring up the wheelchair mobility. So sometimes, in a skilled nursing facility or in any facility, including hospitals, sometimes an individual is put into a wheelchair because they're taken off to X-ray or whatever, and they need to be in a wheelchair, and it's not a wheelchair that they're learning how to mobilize themselves. So that's not an assessment. So when we say that we want wheelchair mobility assessments done, that would mean that the person is in a wheelchair in the SNF, and the goal is that they're learning how to mobilize. And so, the person maybe on admission does not know how to mobilize, and so they might be dependent. But if somebody's learning how to, maneuver a wheelchair, that's really what we're interested in. So at discharge, if somebody gets wheeled down to the cafeteria or down the hallway because the family's visiting or they want to go outside and they're put into a wheelchair, but they're not given the ability to maneuver and, they normally walk, and that's not an assessment. So, we actually don't want a code saying that they're dependent when they weren't allowed to actually maneuver on their own. So you would answer no, they don't use a wheelchair. And we probably will provide more guidance on this because this has come up several times, and we actually had an expert panel meeting recently about these items, and somebody did say, make sure you emphasize that in the training. So, yeah. So, you could put me in a wheelchair, right? And if you're rolling me off to X-ray or whatever, I'm going to be dependent if it's not a wheelchair that's set up for me to maneuver. And I probably wouldn't do well anyway. So, but the intent is that the person is being assessed for wheelchair mobility because that's their way of mobilizing. Okay, so getting back to the case study, Mrs. J. So for wheelchair mobility, she, in this case, does use a wheelchair. So we would say, yes, she uses a wheelchair. And, okay, so let me go forward on that. And then the next question is wheeling 50 feet with 2 turns. So it says here, short distance wheelchair mobility. And a standard wheelchair, so that's actually a manual wheelchair, with a right footrest. I guess that's with the right footrest maybe up. Mrs. J was able to wheel 50 feet with verbal cues to use her left foot and right arm to propel forward. She required touching assistance to perform 2 turns. So in this instance, she's able to go 50 feet. It says she does 2 turns, so she does meet the requirement to do of the activity, and it says that she had touching assistance. So how did you code her? Okay. I agree with 4. And then the type of wheelchair used, okay, 1 manual. And standard, it probably should have said manual to be more specific, but you're right, a standard wheelchair in this case was intended to be a manual wheelchair. Okay, next, we've got 150 feet for wheeling, and it says in the physical therapy evaluation, with verbal cues, Mrs. J was able to propel herself 150 feet using a standard wheelchair with right foot rest. I guess that's right foot rest upright. So how did you code this? A 4? I agree. Okay. Type of wheelchair, again, manual. In this case, it's the same type of wheelchair. Okay, with that, we have completed section GG, so I will do a quick review. Thank you very much for your attention. I really, really appreciate it. I know there are a lot of questions. We will do our best to answer. I think actually a crew is headed out to start answering them so that we can also give you some written feedback also as follow-up to the training. As I said before, the answers to the coding scenarios we went through will be posted on the CMS website, so you'll have access to that after the training. Case study answers and rationale will also be coded. So with that, I will just do a quick summary, and then I'll open it up to a few questions. So just in summary then, the items in GG are used to calculate the SNF quality measure. That's the function process measure. The quality measure is about completing a functional assessment for residents who are in the Part A PPS stay on admission and discharge. There is a requirement related to goals that documents that a care plan did include function. A minimum of 1 goal is required to be entered. You are more than welcome to enter goals for each and every item that's in section GG. If you use the gateway question, skip patterns, that does count as doing, for example, the walking or the wheelchair assessment. If you tell us the person doesn't walk or doesn't use a wheelchair, you've completed the walking items and the wheelchair items by default. During a Medicare Part A SNF stay, residents may have self-care and mobility limitations on admission, and may be at risk for further decline, hence our interest in measuring function using these standardized assessment items. Section GG assesses for need for assistance, so that's why I kept on emphasizing, is the helper involved? If so, how much help was provided? And again, goals. So with that, I don't know who was up there first. All right, gentleman defers to the lady.
Hi,
Thank you.
thank you. Again, just for clarification, the quality reporting program requirement is at least 1 goal. Is it 1 goal for self-care and mobility, or just 1 goal in the entire section?
Great, thank you for asking that question. So her question, just to be clear, is there 1 goal required across self-care and mobility, or is there 1 goal for self-care and 1 goal for mobility? The answer is there is 1 goal required for either a self-care activity or a mobility item. So you could code walk 50 feet as a goal and you're covered, or you can code a goal for eating and you're covered. You're more than welcome to do more, and CMS would be very happy if you did more.
Thank you. And then, so you don't have to code a goal for all. So if you're not coding a goal, are you leaving it blank? You are not dashing it. You are leaving it blank? Right.
So Terry, I'm gonna look to you. I don't think the system allows any blanks, right? So is that correct? Or Sharon? So you would be entering a dash if you do not report a goal. So let's say you reported 3 self-care goals, but you did not write any mobility goals, you would need to enter a dash into there?
And that's not a penalty, though, because you've done 1. And you've
Correct. There is not an APU penalty associated with that as long as you have 1 self-care or 1 mobility goal.
Okay. And then my last question is, I just want to clarify the denominator. And the denominator in the early, like one of the very first slides, said Part A patients. But then later on, it was Part A patients minus incomplete stays. So is the denominator all Part A's minus the excluded?
Okay. So the denominator for the quality measure is all Medicare Part A stays. Basically, in order to take into account that some people may have complete stays and other people may have complete stays, we look at the complete stays first and say, okay, do we have admission data complete, at least one self-care or mobility goal? Do we have the discharge data? All three of those pieces need to count if it's a complete stay. So, that count is done, but everybody's in there if they have a complete stay. We also include all the people who have incomplete stays. For the incomplete stays, we look at whether there's admission data for all the function items, 1 through 6 or 7, 9, or 88. We look for a goal, at least one goal. You do not need to report the discharge when somebody has that unexpected discharge, the incomplete stay. And I know we have to revisit that issue. But then the complete stay residents, the incomplete stay residents are added together. So everybody is included. It just, we separate them out in the steps, if you looked in the slides, because we have to make sure that we don't, if there's not discharge data that's feasible to collect because of an unplanned discharge, unexpected discharge, then we do not require the discharge data. But everybody is included. There's no exclusion criteria for this quality measure. So does that help? I think you said it said minus, but maybe it was supposed to be a dash.
Well, as he was saying about the incomplete stays, and you gave your example of that discharge who wasn't necessarily planned, but they said, I want to go home. Doctor says it's okay. We don't want to use AMA for many reasons, but again, I was trying to do an example at my table. So I took 30 patients. I said, okay, 10 of them had an incomplete stay and they met the criteria for an incomplete stay. The other 10 had an incomplete stay but didn't meet it. So they're in the denominator. So I was trying to figure, the higher numbers give you you want them in because you'd get a higher percentage, is what I was trying to kind of get to. Like my own example, you gave the example of 225, and that was the denominator. So
yeah, so everybody's included. If somebody has multiple stays, they're included multiple times. We have, for the quality measure, to get into the numerator, we have to know if somebody's had a complete stay or an incomplete stay. The discharge data aren't needed if it's an incomplete stay. And so then everybody is added together in the numerator for the complete and incomplete based on whether they meet the criteria that were set up. So everybody is included in the denominator. Okay. So maybe you can write me a question with an example, and we can go through it at the end of the day.
I think I'll do my scenario and see what.
Okay, I do want to get to other questions. Thank you.
Hi. My question has to go back to early this morning, slide 22, related to the definition of helper. It seems like we've adopted the rules from section G where it has to be staff member only. My concern with that is if you look at the LTAC manual, the IRF manual related to section GG, which is supposed to be a standardized uniform assessment, they do not have that definition of helper. So we've restricted the definition of helper for the SNF setting, but we have not restricted staff only. I mean, I don't see it anywhere unless you've added it to the other PAC settings. So to me, the data is no longer interchangeable or uniform when you've narrowed the definition of helper. And in the first 3 days, there's a lot of staff members who are, a lot of family members who are very involved, especially at the beginning, because it's a new setting. So they may, when my dad was in the facility, we fed him all his meals.
Yeah. So Terry, I think you can address this. I think this, Terry, I don't know if you want to speak to this issue about the helper definition, so I don't know if you're able to come up here and address it related to the helper. But in general, I'll start to answer, and Terry can maybe provide more insights. But in general, this does need to be an assessment, so most of the time in IRFs and LTACs, the therapy or nursing staff will be doing an assessment, and if a family member does come in and, let's say, feed somebody, regardless of what setting, we would want a professional to allow the person to be as independently as possible. So,
But I guess my question would be, in the IRF setting and the LTAC setting, because it's not in their instructions, are they following that same definition because it's not in writing like it is in our manual? So again, it's a difference of coding instructions, so the data is not the same.
So, I did the IRF and LTAC training. Terry was there. So we did emphasize that it should always be an assessment.
Yeah.
Terry, I don't know if you want to
I
add
would agree
anything.
with that. It doesn't include family.
So you can, okay, so this is another issue. Terry, do you want to address that more?
No,
or
no, I
you
think
feel-
you're correct in
Okay,
saying that
okay.
that we do want the professional. It's an assessment, so we want the professional response.
Yeah, so it is true, and this came up last week also. So if a patient is independent with eating, and you hear that from the staff and you hear it from family members, you can absolutely rely on what a family member says to say they're independent. You can absolutely listen to what a family member says. If the family member says, oh, I fed the person, and then you know that maybe the person can do a whole lot more for themselves, you could listen to that, but I would not take that into consideration. But we absolutely do want you to listen to everybody who's providing information, and you need to use your professional judgment about whether it makes sense. But if somebody said somebody was independent and you're hearing that from a family member with, whatever oral hygiene, that's certainly acceptable. So, yeah, if they're dependent, then probably I would look at the resident, I would pay attention to what the nursing, physical therapy staff said, and, what the family did. If they did not allow the person to be as independently as possible, I would not take that into consideration. But you can... So, okay, so Tara, I might need your help on this one. So the family fed the person every time during the first 3 days, so there was no assessment by a professional about the person's abilities?
I can't count it.
Thank you. I think we'll have to get back on that more specifically.
Because it happens very frequently in our setting.
Okay, we can get back to you on that.
Thank you, and I'm sorry, I didn't mean to...
Thank you for sharing the microphone. But there does need to be an assessment where the person is allowed to be as independently as possible for all of the activities.
Okay.
Yep.
Thank you for everything. This is really more of an observation, but I think it's important to note. I certainly appreciate the slides where we went task by task, and it was indicative of interviewing staff, it was indicative of CNA participation, it was indicative of therapist participation. We've gone through this whole section emphasizing that it is the usual that we are looking for over a 72-hour period, established through the review of health records, interviewing of staff, observation of the patient. Yet when we went to the case study to put it all together, we went straight to the PT and the OT evaluations, which we don't know when occurred, and really kind of focused and zoned in on one discipline, which was not necessarily usual. It was not over a 72-hour period. We don't even really know where it was, and certainly wasn't collaborative. So my concern there is, again, what message is that sending as we're talking about the true components and parameters for this section?
Sure. So thanks for the feedback. It's difficult to write case studies that aren't, 3 slides long, and then it gets distracting. So partially our examples are help to reinforce definitions, give you kind of some unusual examples to reinforce some points or to remind me to make some points. In terms of the usual performance, let me emphasize that the intent of section GG, so for admission, it is 3 calendar days, so often it's actually just less than 72 hours, depending on what time the person gets there. Our intent is to get the person's status as they are admitted to the skilled nursing facility. Absolutely, clinical best practice would be to include physical therapists, occupational therapists, nurses, speech-language pathologists related to eating, for swallowing problems. So you're absolutely right. It would be a more interdisciplinary aspect to communication. You'd be gathering facts from certified nursing assistants. I know we had some examples where it was interviews, and those are in the manuals. So the intent is to get an idea of the person's baseline assessment. We talk about usual because we wanted clinicians to recognize when somebody's first admitted, they might not be performing their best, or they might be, just kind of getting settled. We do often, start therapy pretty early too, so somebody actually might gain function within, let's say on the 3rd day, and so you wouldn't want to report a score that's based on improvement that's already occurred based on intervention. So we do have some written guidance that we've provided that's more specific, so we will definitely post that to help. And I think what I hear is you'd rather some additional examples where there's different people and maybe some conflicting assessment information and maybe some family member examples also. So thank you, I appreciate that feedback. We will work on that. Hi.
We're doing a lot of data gathering on the performance status. And those are the ones that we can't dash. Because we can do an 8.8 or an 0.9, and there's options. This is a process indicator. I'm assuming for the efforts that are going to be made doing all these performance and the discharge, which really isn't directly influencing the process, QM we're talking about today, I assume there's more quality measures coming from all the data we're collecting on the performance status itself?
Yeah, so all I can say at this point, and I don't know if Terry or Sharon you want to say any more, but at this point CMS has finalized a process measure that requires the collection of admission discharge data and at least one goal. So that is what's currently adopted for the SNF quality reporting program. It is basically, are you conducting the assessment and are you setting goals? So that's, I think, all.
So anything else that's been talking about more performance measures are not related to this?
Yeah, no, CMS has a process that they have to go through in terms of rulemaking. So at this point, I can only speak to what's currently finalized, adopted into the SNF quality reporting program. Anything to add? No, okay. Great. Okay, we have, 3 seconds before lunch. So do you have a quick question?
I have 3 questions.
Okay, just one, please, so that I want to be sure everybody gets their lunch break.
Sure. Will there be some regulatory relief for the need or requirement for physician orders for therapy, since therapy is apparent that they're going to be actively involved in
can't
this?
address that. That's not anything that I can help with.
Okay.
Yeah.
This is something that.
Yeah, sorry, I can only speak to GG data collection.
So I want to go back real quick to the example about the clarifying if it only occurs with therapy for the feeding, say if the speech pathologist is doing trial feeding, how would you code that? Because it's not usual. Would you code that as not attempted, or how would you code that?
You know what, I want to check with my CMS colleagues on trial feedings. I just want to be sure I give an accurate scores, accurate guidance, so I'll have to get back to you on that. So if you could write that down, that would be great. So Mark, okay, here you are. I know it's lunchtime. I will come and talk to you. I know you have a question, and we will have questions at the end of the day, so the lady in the blue shirt, come up at the end.
Thank you, Anna.